I'll have to think about it.
And then it's already sandwich, but other quiz guy.
I'm going to post everything today. I'm going to post everything today. All of the for this one and then the other quiz. You guys have questions?
Yeah. Is it possible that I can look at my paper to see an answer that I put?
I'm sorry?
Is it possible that I can look at my paper to review one of the answers I put?
Not right now. Once I'm done grading it, then we can review it together if you guys have questions.
Okay. I can't remember what I wrote for one of them.
No, I cannot unfortunately do this at this minute.
So
Yes.
for the adenoma, I put lymphatic adenoma. Is that fine?
No, that's not correct.
Okay.
Because anytime you put like something to qualify it, you're basically saying that that there's a disease process that's going on. I'm just looking for the broad term.
Oh, okay.
About if it arises from this, then what term would you use to describe that? Because there are many things that can be adenomas.
Okay.
So unfortunately, no.
I'm just making sure, yeah.
That's
Thank
okay. No worries.
For that statistic question, I put, the answer is lungs.
Yes.
I put lung and pharyngeal cancer.
I'll have to review it
Okay.
and then see.
Okay.
I'll accept that. Okay. So let's see if there's
Yeah, where the lights are on here.
this one. On the left.
This one?
Yeah, and then at the bottom. Yeah. Oh, that's good. Can I just use this?
Yep.
I'm just going to move that aside.
So when's Susan get back?
She is coming back on Monday.
Oh, Monday. Be back on Monday?
Yeah, she's flying
So what kind of
back on
meeting
Monday.
was it?
This is a women's leadership conference through IDEA.
Oh, okay.
So, and it was in Italy.
Oh, that's
It's fun.
yeah.
That's a good place to go for a
Yeah.
meeting.
So they keep you guys busy?
Yeah, always busy. How about you? How's it going?
Oh, good. Yeah.
Was it a long drive getting here?
You know, it's
Did you
always
drive?
13, yeah, it's always 13, 14 hours. And, California is a long state,
All right.
and I'm not even to the very end of it.
So you're more towards like the northern.
Pardon?
Are you in Northern California?
Yeah, I'm on the coast, about 100 miles south of the border on the coast.
Okay. That's awesome. Are you going to stay the weekend?
Yeah, I have a daughter who works.
Yeah, Heidi.
You
Yeah,
know her.
I know Heidi. And I didn't know that she was your daughter.
Oh, yeah.
And when I heard about it, I was like, oh yeah, now I can see the resemblance.
Yeah, one of my kids.
Yep, that's working.
Okay, good.
And then, unfortunately, this is not working. We don't have a battery.
You know what? Usually I never use anything.
That's fine. I did that last time.
My
so-
voice is loud enough there.
Okay.
But if I have to,
So
this
it's
one
just,
works.
yeah, this one works.
Yeah. Okay. All right.
So leave that for you. And is there anything else you would
And then
need?
everything just works off of here.
It should work right off here. And then,
All the thing I have to do is cut down the light.
yes, and the light, you can actually do low. Like how low?
Which one you
Just
usually
press
use?
the down arrow. Right below.
This one?
The high and low.
Oh, down here.
Yeah, right there.
So, doctor.
Oh, okay. That's what I want.
So you can
Okay.
adjust it to whatever setting
All right,
you like.
and then you still take a break 10 minutes every hour, right?
Yes.
Dr. Grun, so this doesn't have batteries, but I did find out when it was on channel 2.
So how
And
do we
down
change
there,
that?
It's on channel 1. I think we could, I think, I'll try to change this, but we have no battery. There's no battery. We couldn't use it anyway because
I'll send an email to computer services. So that's
yeah.
because we have trouble.
Just reminder for tonight, Bible study tonight at 6:30, okay?
Thank you.
Anyway.
I will post the address for those who don't remember.
I think I
And bring
stopped
food, potluck style, bring your friends and your enemies. Thank you.
590. Do you want to start right at 9 or do you want to?
Oh, 9 o'clock. Yeah.
Okay, okay. So we'll do 9 o'clock. Do you need anything else from me?
No.
Okay, if you need,
just give
I'll just
it
write
away.
down my number here.
Oh, okay.
If you have any
Good.
questions, then
Yes.
just call me.
All right. You're in your own. Your office on the 4th floor, or where are you?
It's on 3rd floor.
Or you're on the 3rd?
If you're calling from here, I think there's a place called.
Oh, here's one right here.
Okay, so it's 59670 is the extension.
Okay.
And then my cell number is.
I get here at 6.
I'll see you later.
I like your quiz. So it's half those slides are the ones that I take to my patients. It's interesting to see
I know,
that back
right?
to you.
Yeah, exactly. Dr. Richards shared some of those pictures with me.
Yeah.
Thank you. I'll see you later.
All right, great.
No, I hear you.
Sometimes maybe I'm thinking about driving and I'll think about other stuff. Whereas when I'm here, it's like, I don't have to worry about time. I'm just studying here until then I'll just look at time like, oh, I'm
I just feel like I like to break it up into portions. Okay, I'm gonna go. Don't come around. Otherwise, it's like my get everyone. Are you good?
So she gives you guys that on your computer. What do you guys see? You see her PowerPoint, and then you also have her notes too. Yeah, both.
We don't have PowerPoint.
You don't have this.
we don't get that until after the
Okay. And then apparently, what I'm told, you don't get the one. You don't get the same slides that are on there, right?
Not always.
She takes some of us.
The
What's happening in the world today? Like there's movies coming out.
But like our network book, like those things will still be done.
Okay. What do you guys use for textbooks?
We have so we have the oral pathology, and then we have
That's the big quick one.
yeah, then we have the Rosetti.
For the Rosetti book too.
Those are both available online in the library.
What do you mean by online?
So like the school gives us access to the library.
So you don't have to buy it?
No.
They're all I check in that.
But you can see the whole thing
You
here.
can read them.
Wow.
That's nice. Oh, it's in our
So can you always, even when you get out, can you do that, or you only do that when you're here?
I haven't tried that. Hopefully, that'd be pretty cool. If they just get it never
And like hurt my back.
You have to do one other one. Oh, okay. That's pretty cool. It's a good one. A lot to read, but. All right, we'll go ahead and get started. So today, and Dr. Richards is gone, so she asked me to come in and lecture. So that was nice. It's nice to be back. I haven't been here for a few years. So I actually have been teaching here since 1970, and mainly teaching hygiene. So I like teaching hygiene students because hygiene students are smarter than the dental students. That's like that. I mean, I had one hygiene student on a final, never missed a question on a final. And I gave long finals. And that was the night before she got married. Yeah. Yeah. That's how mean I was. Give her a test. I didn't let her go. I know. So, my name's Lane Thompson, and I went through oral path here, took a residency back, and I should tell you something about Dr. Richards too. She actually was a babysitter for my kids. How's that? So, a long time ago. Anyway, so, yeah, should tell you something interesting. And I see you have books online, that's interesting. You don't have to buy the books. But something reminded me of something. And I don't know what your tuition is, but I went to dental school here. I graduated in 1965. I still have the bill for one semester for my sophomore year, and the tuition for that one semester was $400. And I still have that piece of paper. So I show it to students every once in a while to make them feel bad. But yeah, well, that's right.
That's 1%.
Yeah. Okay, so we have 3 hours today. We're going to talk about oral infections, which is kind of fun. And actually, one thing I'm going to do is we're going to review Apthous lesions first. I'm going to review it. And the reason why people get Apthous and herpes confused. Okay, now, as far as private practice, I taught here 4 days a week. And I did private practice 1 day a week. In private practice, I did general dentistry in one of the faculty offices, and also I saw path patients, all right, that were referred in. Most of the patients were referred in for oral lesions actually came from hygienists, all right. Hygienists do really a good job of looking at lesions, all right, an excellent job. And so I'm always proud of the hygienists, and we had like 5 hygienists in our practice, or faculty practice, and they were actually very good, and they referred a lot of lesions, all right? So I think hygienists play a really important part as far as looking at oral path. The trouble is oral path, you're going through learning all these names of things, and you saw these things today. Hey, I at least got 100% on the quiz. That was good. But most of those pictures that you saw are pictures that I took when I was here. So I remember those patients. All right? So, anyway, now I lost my thought. But anyway, I know what I was going to say. Okay, it's hard to learn all these names, right? How many will you remember when you get out? A small percent, right? But the important thing is what? Recognize something that's abnormal, right? There was one study that they did that if you learned 30 common lesions, 30 of them, which wouldn't be hard to learn 30 lesions, all right? You would know 90% of what you're going to see from the 30 lesions. And something that I saw in private practice when I did my oral path part, the number one type of lesion that was referred to me was the first slide that you saw today. That actually was lichen planus. But it wasn't so much the reticular type, it was the erosive type. Okay? And it's like you had this slide up here, the one question you had, I thought was a good question. That last one she showed you was, she showed you those gingival tissue red and inflamed and all that. And she asked you, what's the name that you call this? All right? Discriminative gingivitis, right? So when you think of this, so when you see a patient like that, when you see discriminative gingivitis, you think of what? 3 things, right? You think of erosive lichen planus, benign mucous membrane pemphigoid, and pemphigus vulgaris. I mean, pemphigus vulgaris is rare, you don't see that very often, in usually older patients. But I ended up seeing a 14-year-old kid that had pemphigus vulgaris. Actually, it was a nephew of one of the secretaries that worked here. All right. So, again, know lichen planus. You're going to see it a lot. Now, how many, which would have been easier to make that diagnosis on that lichen planus? If you had seen both sides, because often it's bilateral. You know, that could help. All right. So I want to ask you, why are you taking oral path? Give me some reasons.
It's required.
Not required. Okay. But if it wasn't required, it was optional, would you still take it? No! Huh? You know what students have said for hygiene students? Maybe they were just telling me that, but that was their favorite course they took in school. Yeah. But anyway, good, but don't be afraid to answer anything. I don't care, and if you give me wrong answers, that's fine. We learn from that. So one reason it's required, right? Okay. Why else? Why else is it important? When you get out and practice, why do you need to know this? You're going to help patients, right? And what's the most important thing you can do in your life? You can save somebody's life. And you have that opportunity, all right? Because if you discover an early squamous cell carcinoma, you're going to help, prevent somebody be disfigured because of some surgery or save their life, right? So that's really important. And again, like I say, you're not going to remember everything, but if you can remember the most common things, that really helps. And here's another reason why. You may not think of this. Can anybody, other than saving somebody's life, can you think of another reason why you should learn oral path?
Protect ourselves.
The what?
Protect ourselves as well.
Protect yourself, right. Protect yourself from what?
Yeah.
Protect yourself from this.
That too. Yeah.
You don't want to end up in court because of all lawsuits that go against dentists, and I could probably say hygienists are included within that group, the ones that actually pay out the most as far as damage go is missing a diagnosis. All right? To miss a diagnosis. And so it's not fun if you get called to court. For my years of teaching here, I got sued one time, several of us did, and it was interesting. It was a patient that actually was referred to me because of lichen planus. He actually had 2 ulcerative lesions down in the vestibule, and he actually saw another dentist first. He was having some pain up in the left-hand side, and so a tooth was extracted. Let's say it was tooth number 15 that had a radiolucency on the apex of that tooth. So the dentist extracted that tooth. He wasn't a dentist. There was a faculty member here, but he graduated from here. He extracted that tooth. He did not submit that radiolucency for microscopic examination. Okay? So he threw the tooth and the tissue away. So actually he was having I guess the dentist, he was referred to somebody else. The patient didn't like that dentist. He went somewhere else. Still had this weird pain in this area. So the patient, dentist looked at him and he saw these 2 lesions. So he referred the patient to me. And I made the diagnosis, erosive lichen planus, all right, on both sides. I gave him some medication. Can you remember, if somebody has erosive lichen planus, what would you treat him with? What type of medication? Do you remember that? Topical steroids. And that's what I gave him. Actually, I gave him kenalog-norabase, which is common. Not very strong. Okay. So I let him go. I wrote in the chart this what it was, and actually referred him to an endodontist. Okay. 6 months or a year later, that guy came back to me. He said, I feel something growing where that tooth was extracted. But what was growing out of there was a very aggressive squamous cell carcinoma. Okay? Now looking at that, I was pretty sure that was probably malignant. All right? And so that periapical lesion that the dentist saw on the end of that tooth was not a apical cyst, it was a squamous cell carcinoma. So he should have done what? He should have submitted that tissue for a biopsy. So, of course, he got sued. He ended up saying, I don't know the right term here, but anyway, he ended up not having to go to court, but he got sued and had to pay his insurance company $250,000 for that, okay? So anyway, when I saw this patient, I referred the patient to the ENT up to the hospital. They did surgery on this guy, but it was very aggressive. So it ended up that he was going to lose his life, all right? Because of how aggressive this lesion was, even though they did surgery. So they sued me, the endodontist, and the hospital, and the surgeon, and everybody. So we went to court. So what they did to go to court, they were actually did a fast track in the court. Fast track is to bring somebody in early, so over the normal procedure, normal time it would take, because he was going to die. They were going to roll him in on a stretcher into the court. And this was Monday morning. Court started. We all had to be there. He died Sunday night, which was lucky for us. It was. Because can you imagine what that would look like in court?
Yeah.
Yes.
Yes, that's pretty
Yes. Right. So I got sued too. Reason I got sued, they said this lichen planus was related to this apical lesion, which had no relation whatsoever. But they got an oral pathologist from San Francisco to testify that this lichen planus was related to squamous cell carcinoma. All right? Money. Right. Okay? So anyway, the other thing that's important I want to tell you, make sure that you write everything in the chart. Okay? Because the first day I went to San Bernardino and went into the court, I'm waiting in the foyer, and here somebody walks in with this big printed stuff, and while I'm waiting, I'm looking at that. I thought, boy, that looked familiar. It was a copy of my chart. All right? So that changed how I wrote in charts afterwards. Not that that was wrong, but that taught me a lesson to write how you write in the chart. All right? So anyway, so I sat for 3 weeks in court, and the prosecuting attorney for that patient, they were suing us for $2 million, was also a dentist. He was a dentist and an attorney. All right? The other interesting thing of court, first day I went to court, I saw, we had a lawyer, but then the university had a lawyer, and I met him the first time at the court, and he looked like a young teenage kid. Well, I thought, oh man, we're in trouble. I'll tell you, this was the smartest guy I've ever seen. He was unbelievable. Anyway, we won. We should have, because it had nothing to do with us, all right? And I'm sorry the guy died, but luckily he passed away before they rolled him in on the stretcher. So the story of this, catch something that's early, all right? And so lucky that's the only time I was ever sued. It was a good experience. I wouldn't want to go through it again, all right? Okay, so let's review Apthous. How many people have Apthous lesions, canker sores? All right, so just about a third of them. Okay, so in canker sores, and here's what is confusing. In the dental office, you need to know the difference between Apthous lesions and herpes lesions, all right? There is a lot of confusion between that, not only by dentists, hygienists, but by physicians. So a lot of these patients that were sent in to me that maybe have recurrent Apthous lesions, they were usually treated with antiviral drugs by the physician because they got it confused. But it's actually not that hard to tell the difference between the two, all right? And when I get through with you today, you're going to know the difference, all right? All right? So that's why I want to review this a little bit. So, you had this already, right? Apthous, okay. So I always thought the Apthous along with infections, although it wasn't an infection, this is an autoimmune disease, because the two are there's a lot of similarity between the two, all right? So again, Apthous or canker sores, very common. First described in 1888, way back, okay? Average age is kind of your age group, but young kids can have abscess lesions too. As you get older, usually you won't have abscess. It kind of goes away. Yeah. Unless you're immune depressed, all right? Of the general population, about 25% of the people have abscess lesions. They've done studies at dental students or just students, and that runs about 50% usually. When you have one of these things, you usually have 1 to 3 ulcerations, and they last 3 to 7 days. And yeah, they're painful, all right? And I had them at one time. I don't have them anymore. And I've had kids that have them also. Okay, so there's 3 types of abscess lesions, all right? 90% are the abscess minor, all right? Usually what you see. Here's the one that's confusing, herpetiform abscess. Because you're going to get that confused with herpes that we're going to talk about today. So it confused other people also, right? Because what name do they put here? Herpes, right? Right? Has nothing to do with herpes. But it looks like a herpes infection, all right? So herpetiform abscess, we're going to look at that. And abscess major, that's not a fun one, all right? Because to those of you who have had abscess minor, you know, man, that's sore for 5 days or so, all right? Really tender. Can you imagine having 1 3 times as large as that and several in your mouth at one time and have them in there for a month, all right? Some people at abscess major, they're there all the time. So students that have them, they don't do too well. Adults that have abscess major, they have a hard time functioning, you know, because of that. So we're going through this quickly. So this is abscess minor. And, you know, when you see an abscess minor, when you first look at it, first of all, you get a little prodromal symptom, right? You get a little burning in that area. You think, oh no, another canker sore, right? If you looked at the area, it's red, and then pretty soon it kind of blanches, and then pretty soon it forms an ulcer, okay? And so you get something that looks like that. And the other thing about abscess lesions, they usually occur on mucosa that doesn't move, right? Usually not on bone, mucosa that has bone underneath, all right? So the vestibule is a common area. The tongue, lateral border of the tongue, on non-keratinized areas is where you're going to get these things, all right? Okay, also, you had this in your notes also. Dr. Richard sent me the copy of your notes, but there is kind of an inherent predisposition. If both parents had them, this is one study. You got 90% chance of having it. One parent, 60%, either parent's 20. So, personality, you know, the uptight person we think usually gets these types of things. Repressed hostility. Is that why I got those? Repressed hostility. Okay. So, a lot of different things. I mean, you can go to the library and look up. I mean, I have a folder this thick just on etiology of abscess lesions. Nobody really understands what causes it because it's different for different people. All right? Totally different. Some people is, you know, you get upset about things, or maybe some people what you eat, and we'll list some of these things that causes these abscess minors. Okay, symptoms. Again, I talked about that. You get little prodromal itching, 1 or more lesions. You get this red halo that I talked about. But here's the thing about them. No vesicle. Abscess lesions do not have a vesicle. All right? Now, herpes lesions do. All right? But the trouble is, most of the times you see a herpes lesions in the mouth, the vesicle has already popped. So usually you won't see the vesicle, although you'll see it out in the face as we show you today if it's out around the mouth. I had a pointer here a few minutes ago. Oh, here we go. Okay, what's the factor? Well, again, we don't understand. 3 main things. If you have a lower immune system, all right, that can do it. If you decrease mucosal barrier, that means your mucosa for some reason. Well, one reason is, okay, about 50% of the things that cause abscess minor is trauma. So if you bite your cheek and you get a little ulcer there, that's going to heal in a day or 2, right? But a lot of times you bite your cheek, you get a little ulcer, but it initiates then into an aphthous minor, and it lasts up to 7 days, something like that. So if we have decreased mucosal minor. Now, how about smokers? How does smoking relate to aphthous minor?
It decreases.
It decreases it. Why?
More keratinization.
You more keratinization, right? Because you got more keratinization you have that smoking causes, you increase that mucosal barrier, and so you shouldn't smoke just not to get abscess lesions. Right? And then increased. Well, okay, we won't have that. It wasn't working a while ago. Oh, there we go. Okay, so antigenetic exposure. So foods, toothpaste, things like that, things you eat, that's a possibility too. But they really can't say any of those exactly. Here's a couple more. All right, again, areas that are in tissue that it doesn't have keratinization. All right. Okay, let's just look at some of the factors again. Maybe vitamin deficiency, B12. Some studies show that people have routine ones all the time. Sometimes they're deficient in vitamin B12, a certain percent. But other patients that have these all the time, they put them on vitamins and it didn't help. Others it did. Hormonal thing can do it. Stress. This is a major one. Okay? Bacterial agents, possibly. They used to think it was related. Viral, unlikely. Trauma is actually a major one. Does it? All right? In fact, they usually think that it was caused by a certain strep at one time when you went back. Food hypersensitivity. Some people say, people that get Apthous minor, can you say anything, anybody can say anything that if they eat causes them?
Oranges.
Pardon?
Oranges.
Oranges, or sometimes pineapple. Some people will do it. Chocolate, some. Strawberries for others. Okay? But interesting, they did a study out of the dental school in San Francisco quite a few years ago. They took patients from the clinic, and I think they used three main things. So they took a bunch of patients, and they divided them in two halves. One half they gave chocolate, another half, then the other. They also gave that half for a couple of weeks strawberries, and then another one was nuts, maybe walnuts. Because I have one of the oral pests people that used to teach here, he walnuts caused them on him. So then they looked at that group compared to the group that wasn't on anything, and they couldn't see any difference. So their assumption was, it's not related to food hypersensitivity. But some people will say for sure certain things, like pineapple, certain things. So the condition is, we don't know for sure. Here's something too. Sodium lauryl sulfate. Where is that found? Toothpaste. So there's been studies on that maybe that causes it also, but they've kind of backed off on that. And then there's other syndromes that can also cause that. So how do you treat it? And somebody answered, you treat them with steroids, right? Topical steroids. A good one is kenalog and orobase. Are you familiar with that? No? Kenalog and orobase, you know what orobase is though, right? You can go to the drugstore and buy orobase. It's in a little tube, okay? And it's kind of a sticky material. You put it on the lesion and it should kind of put a barrier on there. The hard part is it's hard to make it stick on a wet surface, all right? The other problem with kenalog and orobase, it's not very strong. But if Apthous minors, if you actually, when you feel that prodromal symptom on some people, if they'll put kenalog and orobase on it and you get it to stay there, it will abort. The lesion will abort. Okay. So it's topical steroids, and another steroid you can use also, and you may be familiar with this. How do you treat erosive lichen planus? Did she talk about that? Steroids also. A common one was Lidex gel. Did she mention that? It's in your notes, I think. Fluorocinonide. Yeah, that's Lidex. Okay. So you actually could treat this with that too. You could actually mix that with the Orabase, and it would work. Anytime you get a topical steroid, but most people don't treat it. Why? It goes away in what? 3 days, 5 days, right? But if you get Kenalog Norabase or something on there when it first starts, you can get it to abort in most cases, which is kind of nice. It's worth doing. Tetracycline mouthwash also will help because tetracycline kills the bacteria on the surface, so it goes away faster. One of my patients was a physician who had these all the time, and topical steroids did not seem to work too well on her, but we used tetracycline mouthwash. She would rinse with it. You'd get and it's hard to find a mouthwash now. You have to make your own because they didn't want to. It used to be in a solution, but they don't like to give young kids tetracycline, things like that. So you can make up your own solution. But you take the tetracycline mouthwash and rinse with it, swish 2 or 3 times a day, and you can get them to abort. That works really good too. Xylocaine viscous, that takes the pain away, doesn't make it heal anything. Self-remedies, you can find all kinds of, get on the internet. You can find, great-grandmother said to use this, right? And it usually works. Why? Because if we think something is going to work, does it work? Yes, it does. Studies have proved it. Yeah, it does. All right? Chlorhexidine, that's what, Paradex, right? Okay. I've been away from this for about 4 years, so you got to forgive me if I don't remember some of these things, okay? Vitamins, Benadryl elixir mixed with kaopectate, that kind of just covers it. Apthous was something you could buy just for Apthous lesions. Helps some, all right? But again, the best is steroids. And I've actually gone back and reviewed the hygiene national boards you have to take, all right? And that was one of the questions. How do you treat Apthous lesions? And it was topical steroids. All right. Okay, so here we go. Kenalog Norabase, Lidex gel, any mixed Lidex with Orabase, Decadron elixir. You ever heard of that one? No. So it's a Decadron. I use that a lot too. Decadron is elixir, so it's like a steroid. So actually, you could rinse with it if you had several. Let's say when we talk about the the second one. I'll talk more about that. Temovate ointment is a really strong steroid. I use that in some cases of erosive leukoplakia. All right, that the Lidex wouldn't work on. You can also. Are you familiar with Smooth and Seal? Anybody know what that is? All right, you could go to the pharmacy and buy that. My hobby is wood turning. Okay, I do a lot of wood turning. I teach wood turning and things like that. So a lot of times I get a little cut on my hand. Or working in the dental lab, you get a little cut. How for years, if I get a little cut, what did I put on the cut? CA glue. Crazy glue, right? Yeah. That's what Smooth and Seal is. It's crazy glue. So actually you can buy it. It has a little stick with a little cotton thing on the end of it. And you can dry the area off. You can dip this in the little liquid. You put it on the lesion, let it dry, and it forms like a plastic seal over the ulcer, and it takes the pain away. It seems like a lot of work, but you can do it. Debacterol, that's interesting. Anybody familiar with that one? How many of you ever worked in a dental office here? Okay. So some dental offices have debacterol in their office. It's a caustic material, and it's on like the end of a stick. And when you get an ulcer, you take that stuff, you dip it, and you put it on the ulcer. And when you get on the ulcer, it's like you fall on your knees. It is so painful. All right? But the pain only lasts for about 5 minutes. After that, you have no pain. Why? You killed all the nerve endings. Yeah, that's why. So, dental offices, you can't buy that, but the dental offices could buy that. Listerine helps a little bit. And Listerine studies show that it could decrease it a day or two. All right? Because why? The antibacterial properties of the Listerine. Xylactin is similar to Orabase. It's a film that you can put that covers things. All right? Anybody, if those who get Apthous lesions, do you treat it? Anybody, do you treat it? If so, with what? No. You just let it be painful. You're ornery for 3 or 4 days? Is that what it is? You got an excuse to be ornery that way, right? Okay. Okay, here's the one that you may be a hard time. Herpetiform Apthous. Now, you get these lesions all over in the mouth. This doesn't happen very often. Again, it only makes up about 5%. But you can get 100 of these lesions in the mouth at one time. All right? And who usually gets this, sometimes the young females are the ones that get this. Now, let me ask you a question. This patient comes in the office. They've had this for 3 or 4 days. What are you going to ask them to help you make the diagnosis? Any questions you want to ask? How often? Yeah. Or how often, or have you ever had it before? Right? And that's the best question to ask. Why is that a good question to ask? You pardon? Speak loud.
Differentiates between other ones.
Differentiate from what? To different. No, well, major wouldn't have all these lesions. But you reading it on the answer, we haven't had it yet. We're going to differentiate it from herpes, because herpes would look very, very similar. Okay, very similar. So this young gal that came in, have you ever had this before? Yes. She's had it 4 times before, or 3 or 4 if I remember when I took these pictures. All right. So now I know it's not the intraoral herpes, our primary herpes, okay? And the other thing you could say, well, she doesn't have any blisters here, right? But in most cases of herpes, the blister is going to have ruptured the time you see it. So in herpes, you probably aren't going to see the vesicle, right? Does that make sense? Okay? And these things usually soft tissue. Once in a while they can be on bone too, but if you look, most of these are on soft tissue. All right? So, how are you going to treat this? Now you know, you have a pretty good idea. You think you know what it is. What are you going to treat it with? Topical what? Steroids. How are you going to treat that with, what's topical steroid you're going to treat it with? A rinse, right. Okay? You're not going to treat it with Kenalog Norabase, right? How are you going to get Kenalog Norabase all through your mouth? So, what rinse did I tell you that would be a good one to use? What I gave her. Let's go back. What one? What one's? The Decadron elixir. Right. So she could rinse on that. You rinse about a minute or 2, and then you spit it out. You do that 2 or 3 times a day, and those are gone. Does that help you? Make sense? All right. Now, you may say, well, wait a minute, I can't write prescriptions, right? Hygienists still can't do that, right? Okay. They need to let hygienists do more things than they so far do. I've always been pro-hygiene. Right. But you may not write the prescription, but you can do what in the office? You can tell your dentist who doesn't know the diagnosis of this, right? Say, hey, have you ever thought of writing a prescription for Decadron elixir? What? He'll get the book and look it up, and you'll know the answer. See? Okay? Here's another case of it. See that? Look at the lesions. Again, ask if they've had it before. That's a really important question to answer. Okay, so these may have up to 100 lesions. They're smaller. Young females, usually young females. Once I've seen it, usually that way. May have recurrences. Some lesions on keratinized tissue. Usually not, but it can be. Don't let that fake you out. All right? Okay, abscess major. One you wouldn't want to have. Okay? Here's a young girl that came up to clinic, 14 years of age. All right? when I saw her, and you would probably have seen these slides before, right? Okay. So when I saw her, she's been losing weight because she can't eat, right? And so look at these lesions she has. This is buccal mucosa. Here's the other buccal mucosa. She's looking sad. I told her to look sad, but she was a happy girl. But it was really suffering. All right? Look at these lesions. Look at these. This is her soft palate. This is her tongue. So she has gone through a period of 6 months or more that's never gone through a period of not having lesions in her mouth. Wow. Can you imagine the pain she goes through? No wonder she's losing weight. Okay? So it's pretty easy to make the diagnosis in a way. So now, what do you do for her? Treat her with what? Steroids. Right. Okay? And the way I treated her back then, this a few years ago, would be different than I treated her today. But back then, first thing I did, I had her rinse with xylocaine viscous, all right? Because that would numb her mouth. Then I had to take her 2x2 and wipe off these lesions. Why did I have her wipe them off? Got rid of the bacteria, so then the medication, the topical medication, would work better. Does that make sense? Okay? And then I had to put, after that, I had to put kenalog norbase on it. All right? Now I would probably use something stronger like the fluorocinamide, and then use a rinse. Okay. Oh, and I also had to put a tetracycline rinse. Okay. A few days later. Whoops. Here's what she looked like a few days later. All right. Now, I can't prevent new ones. All right. But actually, you can make them heal faster. And so, I don't know what happened to her later, although she called about a year later, and she was having some vaginal problems, and they want to know if that could be related. I said, I don't know, it could possibly be because of autoimmune. But these people that have this, and another thing they treat these people with that really works well, I had another young boy that had these. I used topical steroids, didn't affect it whatsoever. But they put him on, somebody help me here, what is the medication they used years ago? They gave pregnant women, and when the kids were born, they often would have abnormalities, arm and stuff. Can you help me on that?
It was like the anti-nausea medication.
Had what?
It was like the anti-nausea medication.
Could have been, yes.
They made a movie on it.
Yes. Can't think of the name. But anyway, I put him on that, and these things were gone. Well, I didn't put him on it. The physician did, and these things were gone. It stimulates your immune system, at what it does. I just about had the name. But, huh? Thalidomide. Yes, it was thalidomide. Yep, that's what. And those things were gone on him in a couple of days. So some patients, that's the only things that worked is thalidomide, because it stimulates your immune system. Okay, same etiology as the minor, and you get scarring with these, all right? And may last for years. All right, and here's another patient. Here, this guy came from Las Vegas, came to see me up in the clinic. Look at this, and he had a similar, this had been there for a couple of months, and he has a similar lesion on that side. He was in trouble. When I say in trouble, he had thought about suicide because of this pain, and he admitted that. Said nobody could help him. One dentist told him he needed to brush it more with a toothbrush. Well, that didn't help. Okay? So here he was. I put him on the same thing. Topical xylocaine. I put him on topical steroids and tetracycline. He came back from Las Vegas. Hitchhiked back. Just say thank you. Here he was 2 weeks later. Healed. All right? So again, think of steroids. Okay, here's another. Look at. How would you like to have these? Here, and these things heal with scars. Now this is from our files. I didn't see this patient. But look at all the scarring where we've had multiple lesions. So that's Apthous major. Your chance of seeing somebody in your practice, maybe you'll see one, maybe you won't. All right? But you're going to see a lot of Apthous minor. but the etiology is still the same. All right. So now we reviewed that, right? If I gave you a quiz on it, you'd be in good shape. All right. Okay. Now I'm going to show you some things today that you probably haven't seen before, but maybe Richard swiped some of my slides and you've seen them before. If you have, you tell me. All right. So over the years, I've seen a lot of weird things here. Okay. So have you ever seen this slide before? Okay. So I didn't see this patient. This was a patient that in LA. She went to see her. She had a tooth extracted. Went back 5 days later and said, "I feel something moving around in that socket." All right. And so the dentist reached in there and pulled this out. This was a worm that was in the socket of that extraction site.
How do you get a worm?
How?
A fly.
When you eat today, you're going to go eat a salad?
No. Oh, so she ate salad.
Probably, I don't know what she ate, but it was something that she ate. Yeah. Okay, so now we're getting on today's lecture. So we're going to talk about oral infections. We're going to talk about viruses, fungi, and bacteria. Okay? So the important one we're going to talk about, one of the main ones, is herpes lesions. All right? Okay. So the herpes family is one of the most common type of things we have. I mean, we have colds, can be virus colds, or an infection in our mouth. Another common one, like Apthous lesion, which is not a viral infection, it's autoimmune. But one of the most common things we have in the mouth are actually herpes lesions, all right? So how many in here get herpes? Nobody? You're not telling me the truth. Come on, I admit it. I get herpes. So you get herpes. See, we got one honest person in here. In fact, I thought I was driving down here yesterday. I thought, oh, what do you get? You get that tingling? Oh man, another herpes. Right? Okay? So how many of you in here have antibodies to the herpes?
Antibodies?
Yeah. How many of you have had herpes? I can guarantee you 50% of you have had herpes.
Yeah.
You don't know it, but you've had it. Okay? I'm going to tell you why and how. Okay? Did you read the news yesterday?
Yeah, Coachella.
Coachella! Yes! You read that too!
She was there, so.
Or you were there! Did you read it?
I did.
Okay, see if I get this right. My wife read it to me while I was driving the car. So I may be wrong, but you can correct me. And this, I thought, oh, I got to say this in this lecture today. So what they say, normally the genital herpes, they only see, what, 12 cases per day or something? So they saw 200 cases?
What?
200 cases of genital herpes during the concert. Was that per day?
Yeah.
That was per day.
Like where they called in and where where they were symptomatic, like, oh crap, I think I have herpes.
Oh, okay.
Yeah,
All right.
and then of those cases they come in and it was like spread all throughout.
So they were doing a lot more than just listening to the music, is what you're saying, right?
They were at the campsite.
Well, they're at the campsite.
Yeah, that's probably where a lot of it came from.
Okay, all right. So up where I live, I'll tell you, how many people live north of Sacramento? Anybody? Where do you live?
Like before, 30 minutes from Sacramento.
Where?
Henry, Auburn,
Oh, okay. Anybody else up there? Where?
Marin County.
Oh, Marin? Okay. Anybody from Eureka? That's where I live right now. Anybody from Southern Oregon?
From Washington.
From Washington? No, Southern Oregon, so. The night before I left, I had 18 kids staying at my house.
What?
Can you say a house of 18 kids?
How old are they?
You know, they were from Medford, from the Adventist Academy.
Oh.
They were on a music trip, traveling through. And so they showed up. I knew they were coming, of course. Well, my granddaughter was one of them. So they were giving concerts, traveling around. And so that was fun having 18 kids in your house one day, one evening. Yeah. So, but they were from the Medford school. Okay, so only one person, two people. He and myself are the only one that has herpes here, right? Oh, you. You're going to say it too.
Well, I've had them. I've had them.
Varicella zoster.
Oh, varicella zoster?
Yeah.
Okay, you've had that?
Well, I had the biggest one.
Oh, okay. All right. But we'll talk about herpes other times. Okay, so read this. Now, this is paper from a long time ago. You know when you go to the grocery store a lot of times, they have these little newspapers, right? Okay, and you know while you're waiting in line, you can't help but read it, right? So this caught my eye. This was a long time ago. Wife gets herpes and sues husband for $6 million. Wow. Now, so I looked behind me and there was nobody I knew, so I bought the paper. All right. Now, a couple of years ago in the newspaper in Riverside was a lady was suing her so-called boyfriend, I don't know if he was a steady boyfriend, for $3 million because he gave her genital herpes. So yeah, she was suing him for $3 million, and she won the court. I think she won. For $3 million, give me genital herpes. I don't care. Right? So anyway, I got to tell you one other thing. So we use what I'm trying to get across to you. Sometimes we're scared to use the term herpes, right? But 50% of you have the herpes virus, maybe more. You had it at one time. Okay? And I'll tell you more about it. But here, let me tell you another story in the clinic. I was called up on the clinic when I was here to do an oral path consult. And it was a lady about 60 years of age, and she had a lesion, and I was in a hurry, and she said, student wanted to know what it was, and the patient wanted to know what it was. I said, oh, that's herpes. And the lady looked at me, and she said, I'm not that type of lady. I thought, oh, I said the wrong thing. Now what do I do? So I said, I have herpes. You know, and then everybody around me, the cubicles looked over, at me. Oh, I do. I get these things all the time. I get them every month. They get the herpes lesion. Okay? I don't know why. I mean, I get them so often that one of my kids, I did a lot of work in, I like woodworking, and when he was young, he would be down in my shop doing woodworking, and I'd be drinking a Coke. I don't drink Cokes anymore. I gave up on that caffeine stuff. But, so I'd have a bottle of Coke there, and he would want to take a sip of my Coke. Now, I don't know, he was 10, 12. Dad, you got herpes? And I'd say yes or no. So if I said no, he knew he could drink out of my Coke can. But if I said, I got herpes, he knew better not to drink out of my Coke. Okay? So, all right, so let's talk about herpes. So, it is a common viral infection. Upper respiratory infection is very common, okay? So, it is a virus that likes epithelium, okay, and likes nerve tissue. So let me ask you a question. It was burning here yesterday, and I think, okay, I'm going to wake up this morning and have a nice herpes to show you, okay? But I don't think it's coming. Where is my virus right now? Because it didn't come to my lip.
Spinal cord.
It's up in my trigeminal ganglion. Yes, in my brain. So, and then when certain things happen, when it gets stressful, that little virus runs down the nerve and replicates, all right? And gets into cells and causes the lesion, all right? So it loves epithelium, it loves nerve tissue. Transmitted by direct contact with lesions of infected fluids. Okay, so if your boyfriend or spouse has a nice oozing herpes, you should be not kissing him, right? It would be okay if what? Huh?
If it was like a scab?
If it dried up, a lot of times if it dries up, it's gone already. Okay? Yeah. Or it would, but the answer I'm searching for, well, I'll answer that in a minute for you. Okay, I'll come back and say why, what you still could do. All right? Okay, so 50 to 90% of the people have antibodies. If you went back, let's say if you went back to 50 years ago, 90% of everybody had antibodies to the herpes virus. 90. Now it's 50. Why 50 years ago was it 90 and now it's 50? What do we do different? We're a little more worried about things, right? We hand wash and we're more aware of things, right? Okay? And maybe we don't live as crowded. Most people get herpes when they're young. You get it when you're young, all right? So, but now only about 50% of the people have it. Which, this is important as far as you go in your private, in your private practice. Because now we're seeing more adults have herpes than kids sometimes. Or no, not more, but we're seeing older adults. Why? Because they don't have the antibodies, right? Okay? So more people are susceptible. Now, back when I was younger, back 50 years ago, 90% of the people had the antibodies. So when you have the antibodies, you have a resistance to the herpes infection. Does that make sense? Yeah. Now, when you get herpes, 1 to 10% exhibit the primary clinical disease. All right? You get them on the lip? Do you ever have a full-blown primary? Are you aware of it at all? When you were young? No. Yeah, but you don't remember being really sick when you were young. Okay, most people aren't. 90% aren't. But when you get herpes, you think you just have the flu or not feeling good or on a temperature. All right? All right. So most people, when they get the herpes, that they don't have this primary clinical infection that we're going to show you. All right? So that's why when I asked how many people have herpes in here, hardly anybody answered. Why? Because most of you had it as a subclinical infection. You thought you had the flu or you weren't feeling good. You didn't know you had lesions in your mouth. Maybe you only had 1 or 2. But you ran a temperature, but you didn't have the full-blown cases that I'm going to show you now. So most of them are subclinical. But you came across that virus. How did you come across the virus when you did? From where? Parents. Other kids? Your parents? Yeah. Another thing, people that, and we're talking about genital herpes too. People say, well, I got my herpes, my genital herpes from the toilet seat. All right? You know, they give this excuse. Well, actually, they put the virus on a plastic toilet seat, and it actually stayed viable for about 2 hours. Yeah. So you got to be careful on any surface of the virus. You know. Okay, so let's do the type of herpes. There's type 1, which is the oral herpes. Type 2 is the genital herpes, all right? So, can you have type 2 in the oral cavity or type 1 in the genital area? Yes, you can. From oral genital sex, and if you had type 1, you could transfer that to the genital area, all right? So, let's say I get them on my lip. And people say, is it type 1, type 2? I don't care. Who cares? Doesn't make a difference. The only difference it would make, that I'll explain to you, if you had type 2 in the type 2 in the oral area, or type 1 in the genital area, the difference is you have less recurrent lesions. That makes sense? So, would you be better off having type 1 in the genital area than type 2? Yes. Because you would have less recurrent lesions. Yeah. Now, other studies show something here. 22%, 1 in 5 people have type of general population. 1 in 5 have the antibodies to genital herpes. But you're not aware of it. Okay? Most people aren't aware of it. Right? In some countries, as high as 40 to 60%, women more likely to be infected than men. Okay? Now, Either type may be at either site, like I said. 5 to 30% of the cases of genital herpes are type 1. 5 to 30%, okay? So you'd be better off type 1 than type 2, okay? I mean, it doesn't really make a whole lot of difference, all right? And in the oral area, 5 to 20% are the type 2. You would have to do some lab procedures to find out what it is. It really doesn't make any difference, all right? But yeah.
So basically they cause each other?
They don't cause each other, but if you had one, you would transfer that one. No, you would transfer one to the other person. Okay? Yeah. Like, you know, if you got kids at home, you had a nice lesion on your lip, you should be not going around kissing your kids. Does that make sense? All right. Here's the scary part. Transmission. Direct contact with infected saliva, that makes sense, okay? Active, from an active lesion or a contaminated surface, okay? Virus can survive 2 to 4 hours on some surfaces, and they did that on the toilet seat. But here's asymptomatic viral shedding. Asymptomatic means you don't know you're shedding this virus, all right? Is the primary source of transmission. So, does that mean just because you don't have a lesion on the lip and you're exchanging saliva with somebody that you can't give them herpes? You can. You don't have to have an active lesion in order to transfer it to somebody else.
That's scary.
That's scary. All right? So, actually what happens in saliva, the virus can be in saliva, or in the genital area can be in genital fluids, all right? So you can transfer genital herpes to somebody else without that person even knowing they have genital herpes, all right? Or again, well, oral genital contact, same thing, okay? All right? So that, you got to worry about that in a way, okay? The asymptomatic viral shedding. Infected source individual is unaware of herpes infection in 59% of the cases. So most times you transfer it to somebody, you don't know. You don't have to have an active lesion. If you have an active lesion, for sure you got problems, right? Right? But it's not always that way. Source individual most often a family member. Usually you're going to get it from a family member or a spouse. Okay. Are there, before we take our break, any questions? Yes.
Well, there's hardly any way of avoiding it. You know what I mean? Like, you don't even, you know, I mean, my question is, like, it just seems like, well...
Well, it happens, right?
Yeah.
Well, it happens.
Yeah.
Okay, let me put it another way. I have the herpes virus, I know, because I get lesions. What if she doesn't have it? Who's better off? Is she better off or am I better off?
You're better off.
I think I'm better off. Yeah, right. Because see, when I started dentistry, and we'll show you in a few minutes, we never wore gloves. And if I was working on a patient, I have antibodies, I have some protection. And I'll show you what happens in a couple of slides after the break. If you don't have antibodies, what could happen to you if you weren't wearing gloves back in those days? All right? Yeah. I'm just saying hi to our former dean. He used to be my boss, Dr. Goodacre. So what?
If a mom has the virus and it shows it comes out, and the dad doesn't, he's a
Seronegative.
So, and they kiss.
Yes.
And could the dad give it to the child?
Who has it start with?
So let's say that the mom has it.
But the dad would have to have the virus if the dad transferred
Can't you transfer it to the dad and then
to the child if you could? Yeah.
Oh my! I'm so confused. So it's pretty much everywhere, and everyone's gonna get it.
No. Well, it used to be nearly everyone.
It seems like it.
Okay. Let me say one last thing before we take the break. When I I lived in Northern California, and I had a younger brother and sister. 2 different times, both of them were really sick. I mean, really sick. Okay? The mouth had blisters all over it. Okay? And that's back to the time. This is in the 1950s, 40s and 50s. This is a time when the doctor came to your house. Can you imagine that? You just called the doctor and he showed up after work. So both times this doctor came, was a great, one of the most outstanding men I've ever seen. And I remember what the diagnosis was. The diagnosis was trench mouth. That's what he said. He said, oh, they were at different times. When I got into dental school and had this lecture, I realized it wasn't trench mouth. They had primary herpes. Right? So, yeah. So we're going to talk more about it after, so 10-minute break, right?
Did you go to school with a doctor?
Yeah, he was before me 2 years maybe.
He was my boss.
Oh, okay. He's still working?
Yes.
He's got to be about 82, 85?
83.
Wow. Okay. Yeah.
He's still working in Toronto.
Yeah. Yeah. Yep. Yeah. No. He. I remember him from then. I got out in 65. Yeah. You don't see too many people 85 still working.
Still plugging.
Yeah. I have a couple classmates that are still doing it. Yeah.
See, like, he told me he didn't want to retire because he told me he didn't want to retire because then he would start to fall.
Yeah. But you know what? You get connected to these patients that you've
Yeah,
had all your life.
I think it's like, you know, it's a habit.
Yeah, and you love these patients, and you know, the patients say, don't retire, don't retire,
And
don't retire.
that's the thing, he had a real strong drive.
Yeah. Yeah, and it's hard. I ended up, my private practice ended easy. I'm a wood turner, and I was doing something stupid. I wasn't wearing glasses, and a bowl exploded in my face, I think in the eye, and I had regular glasses, and I nearly lost an eye. So I had to quit. I can go back and practice now, but I don't want to. And I'm going to
You enjoy this?
Yeah, and my teaching's going to end. I'm going to teach a CE course here in November, and that's going to be my end of it. Yeah, I'm going to teach in Camp Mayavat this summer at the medical dental.
Were you affected by any of those fires up there?
No, I'm on the coast.
Okay. Oh yeah, Eureka's
on the coast.
Humboldt. Yeah.
No, we were not.
Yeah.
Nothing got burned. Well, I'm right on the coast. Too wet.
Too wet. Yeah.
Everything's green.
A couple of my friends in high school went to Humboldt.
Oh yeah, I'm not far from that. I'm like a few miles from that.
Great.
Yeah.
It was so last minute for me. My brother called me and just told me Saturday I had to be wristband, so I went. Great. Yeah, I didn't take it.
So when does this course end for you guys?
June.
Oh, you still got a long ways to go.
Yeah, 6 weeks.
Yeah, I did most of the time with teaching on arts.
Yeah, but we have, we're taking technically 8 classes right now, so it's a crazy schedule this quarter. But after this, we'll be
You did some of the general path first,
No, this is our only pathology class.
but don't they teach general path also when you start?
General path is in the beginning of this
Yeah,
course.
right. That's what you did
Yeah,
before.
so we have a
The first
test
few
on
weeks.
Monday. Yeah, we have a test this Monday on general path.
Oh, you do?
And then we have a test in 2 weeks on oral path.
That's not, but you still go till June.
Yeah, and then we have our final one, oral and enteroviruses together.
Oh, it is?
Yeah. because we only take one course of pathology, so.
Yeah, right. But actually, you guys, you know, we had lectures 6 hours, I think, 5 to 6 hours a week for hygiene. Is that what you guys have?
Yeah, we have like 6. I think we probably have like 5 or 6.
5 or 6. All right, except it's the same.
Yeah. I think we have 2 hours Monday, 1 hour Wednesday, and 2 to 3 hours on Friday. Not too bad.
Well, it's a little different than the other courses. That's why I just kind of like it. It's different than gingival.
Yeah. I enjoy it. I just wish we were taking so many classes so we could put more focus towards that. Or taking we're taking stereo, which is, it's not hard. Like, the information isn't hard, but we just recently took a test in that class and did that. Just how the information is dark and stuff. Taking film, taking pharmacology, and medicine.
That's both those are different. Who teaches
Miss Hagen. And then
our
then our pharmacology professor is Dr. Hyatt Shaki.
I've been gone here 4 years.
We have a lot of studying to do this weekend.
Yeah. And then I did started teaching when they had the hygiene down at Palm Springs. That was a fun. I enjoyed that.
Yeah.
That was a nice balance.
My parents live out there, so I originally wanted to go to that campus if I could have, but they don't have it.
And it was a neat class.
It was at College of the Desert.
Yes. It was in a separate building.
Oh, yeah.
It wasn't on the campus.
No, like
It was in a commercial place.
Oh.
Yeah. Commercial building. Yeah, beautiful.
They had full dose
Yeah. Oh, that's beautiful. Oh, yeah. Oh, yeah. It was first class. It's glad they didn't get more people applying because but that was funny when I went there. That was my favorite team.
Yeah, he just asked me to go. We were going to go out to dinner after a little break. Some places are about yeah, exactly. We just take it all. I like
So how much is tuition for you guys now a year?
This year was 46.
Oh, a year.
46 for the whole year?
46,000.
For the whole year.
For the next year, so it's like and that's just tuition. It's not even like
So why don't you
okay, that's what I don't actually bachelor's degree. You have to have a master's for teaching, and the bachelor's just gives you
I mean, the tuition
that's really comparable. I was looking at it was pretty slow, and it was about
but you can make what, 360 a day? Yeah, that'd be fun. when I started my dental practice, I got on practice for 5 years before I came down here.
That's why I gave it. Where did you first go to school?
Here.
Oh, you were here.
Oh, really?
Yeah, I went to school here. And then I practiced in Northern California for 5 years.
Yeah.
And then stage teacher. So I've been teaching since here. Yep. Well, when I started, they didn't have the towers.
But I don't care about restrictions.
This was a classroom. This classroom used to be a amphitheater. The lecture was there, back part was so you would see.
There's classes that are like that.
Yeah. But that's all. That was the here originally. This was the Okay, let's go ahead and get started. Okay, so I want you to understand, you don't have to have a lesion to transfer it to somebody else, all right? Because you can have the virus in your saliva and genital fluid without having active lesions, which is scary, all right? Okay, so what are the clinical patterns of a herpes simplex infection, all right? So you can have a primary infection, which we'll talk about. But what percent of the people have primary infections? Do you remember? Small, 1 to 10%. Okay? Most people are going to have, and most of you in here who have the antibodies had a subclinical infection. But you were totally unaware of it. All right? All right? So probably at least 50% of you, or maybe higher, that's how you got the antibodies. So you had a sore throat, you weren't feeling good. You didn't know you had lesions in the mouth, okay? And then you can get secondary infections, recurrent one, and that is our herpes simplex on the lip, all right? That's what you get, I get, okay? So not everybody that has got the primary, both clinical or subclinical, gets the herpes, recurrent herpes labialis, okay? How do you know you're going to get one on the lip?
You don't.
Well, you know, but you know when it's going to start, though, right? What happens? You have a tingling. You have a prodromal symptom, right? Okay. So then, here's the hard one that you can see, and you're, as a hygienist, may cause this to somebody, and not many people are going to recognize that. All right. That's what I want to teach you today, because mostly the dental office you're working in is not going to recognize it. I want to teach you what it is, and that is recurrent intraoral herpes. And then you can get a herpetic whitlow. I have one of those too. All right? So I'll show you what happens is that you can get herpes in your finger. And every year or so, I get a lesion on my finger. All right? And it's a blister. Why did I get it on my finger? I worked without gloves for I don't know how many years. We didn't. Gloves? Why would you wear gloves? You know, I can't work with gloves in the mouth. I mean, that's what we thought back in those days. Okay? You know, can you imagine doing work now without gloves? Wow. I mean, when I was in private practice here in Loma Linda a few years ago, I had a patient who was allergic to everything, so she had me work without gloves. She wanted it. It was just weird to be in the mouth doing it without gloves, you know. But again, I did that for 15 years. Okay, so I'll show you that. So I'm going to show you all those. So primary infection, all right? This is when you don't have the antibodies and you come across it for the first time. Most of the time it's when you're a young kid and you get it from somebody else, a family member, or you get it playing with other kids, something like that, all right? This is to people that have no antibodies. So 50% of you here are susceptible to this. But even if you get a herpes infection now, you can get it later on in life. Remind me, I'm going to tell you a little difference if you get primary herpes later in life than younger in life, okay? So what happens, you run a high fever, all right? You're not feeling good, and so you break out with all these vesicles. But the vesicles do not last very long, all right? So they're going to rupture, so the only thing you're going to see are ulcers, all right? And you can see an ulcer here. I don't know what that is. Maybe one here, all right? It's not too good a picture, actually, on the tongue, all right? Here's your young kid. And a lot of times, you can get it. So look at the vesicle. This is from our book. So you can get it out on the left. So you can pretty easily make the diagnosis. Now, your lymph nodes get swollen, and you run a high temperature, 102, 103, 104. You're really, really sick. And remember I said my younger brother, sister were diagnosed with trench mouth? It wasn't trench mouth. This is what they had. They had both had primary herpes. And they had the full-blown case of it. But the physician back then didn't know that. You know, and I understand why. Okay? So, but they called it trench mouth, which we're going to talk about later. All right? Had no relation to the herpes. But lymphadenopathy is a common thing. Okay, so here's a girl I saw upstairs in the clinic. She came in, the mother brought her in. The mother was a nurse, and she had been running a fever for a few days. And the mother said, okay, I took her to the emergency room. How do you think they treated her?
They didn't know.
They didn't, well, they didn't know what to do, but they gave her something as far as medication. Antibiotics. Okay? So the mother was a nurse, so she said, I'm not, and he really didn't give her a diagnosis. So she brought her into dental school, and I looked in the mouth. This is what I saw. So what kind of questions do you want to ask her or her mother?
Have you had it before?
Have you had it before? That's really important. And how long? So it's had 3 or 4 days. No, I've never had it before. Okay? So she was really sick. Even her face looks a little red. All right? But you can really be sick. Young kids that are sick with this, they can hardly eat. They get dehydrated. Terrible. Really terrible to go through. Can you imagine? Okay. So that's the diagnosis. You have clinical primary herpes. Does that make sense? All right? So these lesions can also occur on the gingival tissue. What other question that I thought of asking that you may want to ask, just for your curiosity? Huh? Somebody, you said something.
Does anybody have it?
Yes. Has anybody else had a lesion, had a fever blister? The mother said, yes, I had one 2 weeks ago. See? So, that was easy to make the diagnosis. Now, here's another guy that came up in the clinic. All right? This guy was about 21. Really, he was a lot of discomfort. Look at the gingival tissue. Sometimes in primary herpes, you get this gingival tissue just erodes away. Right? So often, first thing, he gets red, swollen. All right? Look at all these lesions he had in the mouth. Here's one back here. Here's one of the tongue. He said, I think I have an oral venereal disease. And his girlfriend was there with him. And I said, I don't think so. I mean, there are some that could look like this, but the gingival tissue and oral venereal disease wouldn't look like that. That's probably pretty characteristic. So what do you want to ask him? You ever had it before? No. What else do you want to ask him? What did the girlfriend say?
No.
Yes, I had a fever blister on my left a week or so ago. All right? So they had been what? Changing saliva, right? I figured they were. Okay. Most common thing to do. Okay? And he had no antibodies. So what? He got the herpes virus. Makes sense? So she had to be when they had a nice oozing lesion. Now let me ask another question. What if she didn't have a lesion? They were still exchanging saliva. He had no antibodies. Could he still get it?
Yes.
Yes, because why?
Asymptomatic.
Asymptomatic viral shedding. Does that make sense? See, you're going to know more than most dentists out there, right? Right. So, when I said, no, you don't have an oral venereal disease, he felt a lot better. I don't think his pain was half as bad when I said that. Okay. But it's just classic. But remember, only very few people get to full clinical thing, right?
Why did you think he had oral venereal?
Why did he think?
Why did he come up with that name? He just went on Google?
Well, I don't want to get into why he thinks he had it.
Because is it the others?
Well, you guys, she didn't put, you can't have a gonococcal infection in the oral cavity. Yes, and you get ulcerations on the tongue and things like that. It looks somewhat like this, but not completely. And well, I've seen those in the clinic also. Okay, so that's the primary. Remember, 90% get what? Subclinical. So what? You don't feel good, flu-like symptoms, you don't see the lesions in the mouth. Okay? Now, herpes labialis. Everybody what percent of the people that had either clinical or subclinical get herpes labialis? Only about 20%. Why do we get it? I don't know. Okay? We're just unlucky, I guess. Okay? So it's called a cold sore. More often occurs on the mucocutaneous junction of the right out here. You get prodromal symptoms. When I get one, just like yesterday, driving down, oh no, I'm getting herpes because I'm worried about lecturing to the class. I haven't done this I'm retired. So I was a little nervous about doing it, but if you know me, I'd say anything. Okay, so I got tingling cessation, then you have vesicle forms, and it ruptures, and when that vesicle forms, boy, you're really infectious to somebody else. Be careful. Now, the question is here, what if a patient comes into your hygiene clinic and got a nice lesion on the lip? Do you work on them or not?
No.
They won't let you upstairs, right? Yeah. Would I work on it? If they felt comfortable, I would. I'm not afraid. Why? I have it. I got herpes. Okay. I have herpes. I get a t-shirt to wear to that. That's like we're afraid of the term. Don't be afraid of the term. Most people have herpes. All right? Okay. Duration, okay, can last 4 to 10 days. Some people last a long time. Mine, I have good antibodies to it. When I get herpes, it's gone in 2-3 days. All right? And usually you'll always get it in the same area. Sometimes it's on the upper, sometimes it's on the lower. All right? Could be either. Recurrence variable, every 2-3 months. I don't know what sets it off, but we'll name some of these things here. Here's what it looks like. This is Dr. Richard's lecture. Which of these lesions is the earliest stage? Well, that one's going to be, right? Boy, it's very infectious. All right? This was a dental student. Look how he reacted to it. I mean, this was for 2 weeks. He was like that. All right? Here's one. Drying up. Probably the virus still there. If this was your kid, could you kiss your kid? Probably. All right? Probably dried up. Here's another one. Vesicles. Who is that?
You.
Me. So I'm looking through her slides. I thought she's got me up there on the slides. So, and then here is, probably the virus is gone. All right. Now, well, we're going to talk about treatment though in a while. Okay, recurrent. This is the hard one. This is not common, but you have a chance of setting this off. This is why you should recognize this. Okay? Uncommon rarely occurs at the same type as herpes labialis, which is true. And often people that get this are not people who get the herpes labialis. Right? So, this, I put this in red, occurs on mucosa bound to bone. So you only see this in areas that has bone underneath. All right? Not easy to make the diagnosis. So where are you going to see it? Hard palate and the gingiva. Right? Now, so you get vesicles, and they produce multiple small painful ulcers because they're going to rupture. They can coalesce to form larger ulcerations, and I'll show you a picture of that. Okay? So what they call the coin lesion. Heals again, 7-10 days. Apthous and herpes, when you say how long it lasts, usually the answer is 7 to 10 days. Most cases. Often precipitated by dental treatment. Yes, I'm glad she put that in there. Including and especially periodontal procedures. Okay? So you have a chance of causing this. Well, you may precipitate it. You didn't cause it in the first place. So, this is classic. Okay. So this young gal is about 30 who came in. Said this is the third time I've had this. Every time the hygienist cleans my teeth, I break out like this. Look at easy to make the diagnosis. What does she have? How many? A group of little tiny ulcerations. A group of little tiny ulcerations. Every time she gets her teeth cleaned. So she says, who's she blaming?
Hygienist.
Yes. What's she saying about the hygienist?
Dirty.
Dirty instruments. That's what she said. I know my hygienist is using dirty instruments. I said, no, you have intraoral herpes. Recurrent intraoral herpes. And you kind of have to explain it. Well, I got herpes? What do you mean I got herpes? So you have to calm them down a little bit, right? Okay? So that's classic. If you showed me this picture and didn't give me any information, I would say recurrent intraoral herpes. I wouldn't need like they gave you the history today, which was good. But this one, I would be mean and not give you. Only history I'd say, hey, this is a painful lesion that's been there for 4 days. And you should be able to, I may say, well, she had her teeth cleaned, but that would set it off. It'll give you too many reasons, okay? But that is classic lesion, all right? This is a secretary. She's retired now. Never gets a mono lesion on her lip. Okay, look at this. Classic. Painful, really painful. And then it starts on the other side. It heals on one side. What should you not do? And some people, when you read the book, you shouldn't be, when you brush your teeth, you should take this toothbrush and don't stick it in a drawer. You should put it where? On the windowsill or somewhere. Because some people say you spread that virus from one area to the other. Okay? Here's a couple more. Here is a dental student did a crown and broke out, and then they called me for a path consult, little tiny ulcerations. All right? They thought, well, maybe trauma. Most likely, I'm guessing on this, most likely it set off a recurrent intraoral herpes. Okay? And then you can see it, one on the palate. Here. The practice I was in, private practice, was Dental Faculty Associates, which some of us faculty members practiced in. And I helped start that practice years ago, but I practiced 1 day a week. So one day I was just walking in the office. I wasn't working that day, and one of the other dentists, Dr. Tan. Do you know who Dr. Tan is? No? Okay. He works there too. I think Dr. Roberts said, hey, would you come back and look at a patient? Well, I got Levi's on. No, they don't care. So I went. So we had a woman about 55 years of age that had a sore area in her palate. All right? And they want to know what it was. You know, sometimes you take a chance. And I just had this feeling, and you have to be careful what you say. I say, don't take this wrong, but I think you have a herpes infection. Okay? I said, it's very characteristic of it. Let me see you in about a couple days later. So when I was there, she came back, and she did. So made the diagnosis. But she was just starting to look little tiny vesicles. All right? And she was fine with it. At least she knew what it was. But they are really painful. Okay, herpetic whitlow. So before gloves, what happens, if you had a cut on your finger, then that virus could get in there. And if you had no antibodies, you could get a primary infection in your hand. And just like when you had a primary, these lymph nodes swell up, well, then your axillary lymph nodes could swell up. And it could really be painful. So this was a dental student's wife who actually got these things every once in a while, little blisters. She actually had them cultured. It was type 1 and type 2, which, yeah, it was fine. What was interesting, though, she worked in the nursery in the hospital. So you really wouldn't want to be working in a nursery, would you? Except we have immunity the first 6 months to this. Usually you don't see a kid have this. Remember, a primary usually happens when young kids. Now, remember I said, I wanted to bring this back. You can have a primary in adults, again, because 50% of the people don't have antibodies. There's some in the literature as old as 70 years of age have had primary, right? The difference is, instead of having it on the lips, the little vesicles, they're often in the pharyngeal area. Totally different. Yeah, right, painful. So that is a herpetic whitlow. But now that we wear gloves, we don't see these very often. But look at this one. This one is an oral surgeon. Okay? He's an oral surgeon before gloves, and he worked in his rose garden on the weekend, had a cut, probably didn't know this, went to work, and he had no antibodies, so he got this. He was off work for 2 to 3 weeks. Now we had another instructor a few years ago who was retired, and I talked to him on a clinic. He got these things every so often. Very painful. He would get them every few months. You get a herpetic whitlow and it caused him a lot of problem. I get mine about once a year. Starts to burn, and it gets a little vesicle, and it's gone because I have really good antibodies.
Do these happen just on the fingertips, or can they happen like on the hands?
It could be anywhere.
On the arms?
Could be. Yeah. It could be.
Whole body?
Yeah.
Okay.
Yeah. Yep. But this is the one you have the cuts. This is where you have the cuts. Yes.
Is this part of like the hands, foot, and mouth?
No, we are going to talk about that then. Yep. Any questions on so, yeah, that's, this is kind of a situation that's gone now, though, because of gloves. Common in the health professionals, if that makes sense. Usually on the fingers, because that's what you're working with, that's what you cut. Can get recurrences. I get mine every 1 or 2 years. Can be a source of the primary infection. And on this guy, it was a primary source. Yeah. Okay. Let's talk about treatment. Okay. I get them so often. Do I treat mine? No. Why? They only last a couple of days. Okay? So what is the main treatment? Could be acyclovir. That's one they used to use. Okay? You take 5 times a day, 20 milligrams. That worked pretty well. Still is good. Valcyclovir is good. Actually, it's a new one. Now it's a systemic. What you do is take 1 gram pill in the morning, 1 in the evening. All right? And that works really well. All right? Those are the 2. Lysines, people say, you can go to the library and look up treatment for herpes, and you can find everything. All right? Lysine, over the counter. Some people swear by that to get rid of the recurrent herpes. If you take enough, I guess it helps. Some vitamins help. Topically, penciclovir works really good. Acyclovir ointment works pretty good. If they put acyclovir with hydrocortisone in it, that works pretty good. One problem why topical doesn't work really well is it doesn't penetrate the epithelium that well. Yeah. Where valcyclovir works really well, and that came up using it a couple of years ago. But acyclovir capsules, some people, every time they go skiing, snow skiing, being out in the sun, they get that. So if they start taking acyclovir ahead of time, it prevents it. Right. Yep. Anybody familiar with Abreva? Abreva is a little tiny tube, and it costs about $20 for the little tube. You put it on the lesion. I've tried it. It doesn't help that well. Studies show it doesn't help that well. Helps some. Maybe you'll diminish the duration about a day. Okay. So I would never use it again. I just let it come on and come. Any questions on that? But remember, acyclovir, valcyclovir. Okay. Now I just compared these a little bit. Let's compare Apthous lesions with herpes simplex. Okay? This is a herpes. This is the Apthous. So, what causes them? Apthous, you usually have an immune deficient thing, right? Herpes, it's going to be the virus, right? Now, what sets it off? The precipitating factor. Stress. Probably the main one in both of these, right? Of course, you people are never stressed out. Especially Monday, right? You won't be stressed? You have a test Monday?
General path.
General path. You know, one of the people remind me of that Shelley, I think, was in that class for the final. Shelley Hayden. Hayden. I think it was her class. They always say, "Oh, do you remember what you did to our class for the final?" I had the final and I gave them all the answers.
Tell Miss Richards.
Well, you know, they were a good class.
We are a good.
We are such a good class.
I don't know you guys. I don't teach you. So, but the trouble is, then the class afterwards next year wanted the same thing. So it took a few years to die out. But I was just feeling good that day or something. So anyway, so stress sets it off. Trauma, both. Apthous ulcers is trauma. Ultraviolet, here, out in the sun, ultraviolet, depressed immunity. All right? So, you know. For abscess lesions, you know you're going to get one, but the symptoms are not as strong, but they're stronger on the lip. Because you know when you get in the lip, there's a burning sensation. You know it's coming. All right? And then you keep putting your finger up there, and then you start to feel a little vesicle. So no vesicles on abscess. Remember that. Vesicles on herpes. One way. On Apthous, single ulcers. Non-keratinized mucosa. On this one, multiple ulcers usually, and a lot of times keratinized. Treatment, steroids and tetracycline. Antiviral on the difference, all right? So if I showed you a picture, you can tell the difference now? You'd know what questions to answer or ask?
Well, I have a question as regarding the herpes that came about after the restoration. How would I differentiate that from lichenoid contact stomatitis?
You know, because lichenoid contact stomatitis would have to be there a while, usually. In most cases, like amalgam can cause a lichenoid reaction. Yeah. I mean, the thing you got to think about, and that was my guess on that one. I mean, it could be trauma too, but it looked like it was little tiny,
More dot-like.
yeah, little dot-like things, right? And I have no way to know, but them little things will set it up. But you guys will set off a recurrent intraoral herpes. You may not know, patient may not come back and tell you that, but you will set it off a few times, right? That's why you should be aware of it, all right? And a lot of times, again, it's on tissue. Remember this, that has hard tissue underneath. All right? And I don't know why. Why when you have a primary it can be all over, but why when you have the recurrent on the lip, it's in soft tissue, but why is the recurrent intraoral only on the area I don't know. I have no idea. I often wonder about that. I can't answer that. I haven't read the reason for it. Okay. How would you tell herpes abscess from primary herpes now? How would you tell what's what on this? If that patient showed up in your chair, what would you do? Ask them what? If they ever had it before. Right. That would help. And you said what?
They're sick.
Yeah, well, okay. Both of them wouldn't feel good, but the herpes would have the higher temperature, really sick. Apthous, you not feel good, but you wouldn't be running the temperature. So that's one difference to tell. So you would want to ask also what? Have you ever had it before? And this one said no. Oh no, this one said yes. This was that, yeah. Okay. And so if they've had it before, very characteristic, you know, you can have a recurrent primary herpes in an immunosuppressed person. Yeah, you can. So I shouldn't say you never would get it. Normal immune system, you'd only have it one time.
So the recurrent herpetiform. What's the last word?
Yeah, herpetiform abscess.
Abscess. So that one.
That's what this is.
You can have it a few times.
Yes.
But the herpes, primary herpes,
you only have once.
Okay.
In immune, yes, good question. In an immune person, you only have primary herpes once.
Okay.
This one, usually younger females, and often it helps you. Now, if it was the first time, the diagnosis wouldn't be as easy, right? That would be harder, right? But they're not going to be running a high temperature. But I wouldn't be afraid to use a topical steroid in a case like this. Where in herpes, they usually say you shouldn't treat them with a steroid. They thought because the steroid could make the infection worse, but they backed off on that now. That's like herpes zoster we talked about. Now before they say you shouldn't treat it with a steroid, but now they do. So, you got a question?
Yeah, so if a person has the antibodies to this and they're asymptomatic, are they still, it's still possible for them to get the primary?
No.
Oh, no?
No, that's a good question. If like 50% of you in here who have the antibodies, are you ever going to get a primary? No. Not unless you are immunosuppressed. Then you could, but I'm glad you asked that. No, you wouldn't get a primary. You won't. So, why can somebody have genital herpes and be married to somebody and the other person never gets genital herpes? They have the antibodies. Yeah. Yep.
And there's no way to formulate those and inject people with them.
Yeah.
Right.
So it's like, I have the antibodies, so I'm protected in a way. Okay. You guys clean calculus off teeth?
Oh my god, that's calculus?
That's calculus. There's a tooth under that. A maxillary central.
Oh, this is central.
And this is, I think I still have that one. I don't know if I lost it. Once I took that off, I had it at my desk for a long time, that piece of calculus in the drawer. Why would you save that? The trophy, yeah, that's a trophy. Okay, chickenpox. Oh, man. Okay, glad I get you to 12. I talk too much. Was there any questions about Apthous, you guys? And herpes? So you pretty well could tell the difference if you saw a patient now? Okay. All right. Chickenpox. It's varicella zoster virus. It's a common childhood infection caused by the varicella zoster virus. Again, you get these maculopapular and vesicular eruptions on the skin, and you can also get them in the oral mucosa too, right? You can get it pretty severe, and when you have it severe, you can leave scars. I have 5 kids. One of the girl had this really severe. I'll talk more about her today and some of these other things. But she really had it, and it left some scars, and she was really, really, really sick with that, all right? So now what happens, you can have the vaccine, all right, and it helped prevent that, all right? Well, the other thing in the news right now is, we have a measles outbreak? Yeah, yep, And again, it's really important to get vaccinated on these things. See, anything else we should say about chickenpox? Okay, so once you get this, once you have chickenpox, you still have that virus, right? And it resides in the dorsal root ganglion, all right? Just like the herpes, all right? So it stays there, and it stays there very latent. And then something sets that off, all right? So later on in life, when you're older, all right, you then can get, here's chickenpox, okay? This was actually our oral path secretary's kid who came in, and she brought him in one day and we took pictures. So he got some oral lesions, and here's his skin lesions. He now works in the university here. He's about 35 years old, but anyway, that's a picture of when he was a kid, all right? You may have seen him once. Okay, shingles or herpes zoster. So now you have this latent varicella zoster virus, and it can become dominant again, all right? So you can get recurrence triggered by trauma, cancer, or severe immunodepression. All right. So it's interesting talking about this. So one of my daughters that actually she has MS, so that tells you she's got a depressed immunity. And so she actually sent me a pictures on my telephone here. Said, "Oh man." Well, first she said, "I'm in pain." And you know, we always worry about her because of her MS. So she's about 40 and 2 kids. In fact, one of her kids was one of the kids that stayed in my house the other night. It's a 15-year-old daughter, a granddaughter. So she says, "Man, I got to go to the doctor. I'm having this pain." Well, then 2 days later, she sent me a picture right here. What was there? A nice line. And I said, "Huh, you got herpes zoster. You know, you better get to the emergency room tonight." And she didn't go the night. She went the next day. I wish she would have gone that night, actually, because the sooner and something you should remember, the sooner you get on treatment, the better off you are. You should get treatment within 72 hours, right? And they put her on antiviral. So I called her the other day. I said, "What did they put you on? What do you think they put her on?" Acyclovir. Yeah. Okay. So, and then she was on that for 4 days, took the pain, but now the pain has come back again. Okay. So you can have it about 10 to 15% of the cases. It can involve the trigeminal nerve, and that is really, really painful. Another thing that I worry about is this right here. A certain amount of people can end up with this post-herpetic neuralgia, and they're in pain for a year. Now, another graduate, a friend of mine who I talk to every so often, he just had herpes zoster, all right, and it took him a month to get over it. He said, "Lane, go get your vaccination for this. Don't go through this, because it's, again, very painful, right?" So shingles is not fun. Again, that's the recurrent of chickenpox, right? So now, the other thing about let's show you. Okay, and she sent me a picture, kind of looked just like that right there. Somebody had a question.
I did. So you're saying if someone has a shingles outbreak once, they should still, even though it's rare to happen again, they can get vaccine?
You know, that's a good question, because she asked that question whether she should go get the vaccination now, and she's got to talk to a neurologist first because the MS, whether she should do that or not. And that's a question I have. You know, whether she should get it because of her condition. I mean, she's lucky, she functions fairly well. But she gets recurrences once a year and is in the hospital. So, what else I want to say? I just hope she doesn't go into that post herpetic thing, because I've talked to people that have that, and that is terrible.
What is that? The trigeminal?
Well, no, not trigeminal, but just anybody that has herpes zoster can go into the post-herpetic neuralgia. And that lasts for a year.
What is that?
It is herpes zoster that just lasts for a long time. It's not over in a month. It takes a year to get over. Okay? You talk to people now, what's sets off herpes zoster usually? Some deficiency, if you're immunosuppressed, things like that. Now, thing that my dentist friend who said, "Hey, go get vaccinated for that." He said, "Go get vaccinated for it." The interesting thing is, somebody told me the other day they wanted to go get vaccinated for it, but they wouldn't do it unless because they were not over 65. But some people say you should do it after age 50. All right. So, anyway, but you should get the vaccination if you can.
So you're saying shingles, if someone has a shingles, it's a sign of a very serious underlying cause?
You know, it's not necessarily. It can be. It can be. Shingles is fairly common in people, but it doesn't mean that you have a serious problem. Okay? I remember a dental student years ago who got shingles, ended up having cancer after. Okay? But all kinds of, my dentist friend who has got shingles, I think it's a routine thing. He doesn't have any systemic disease. He's in good health. So you can be.
Can you check their blood to see?
You can usually know by the symptoms. The other thing about shingles, what is it? One really characteristic that helps you make the diagnosis. Anybody know? Well, yeah, the ooze, but it's usually one side. It's not a bilateral.
For shingles?
For shingles. Yeah, I'm glad you, yes, it's unilateral. And I think that'd be, was that on the notes?
Oh, I see.
In the mouth. But shingles can have in the body.
See, it's very unilateral. Now, okay, here. If this is the trigeminal one, how do you make the diagnosis? Unilateral. Look at the side of his face. This is extremely painful. Yeah. Can you imagine having that? Oh. How about this? Look how it's unilateral. So, but in cases, some cases, your question is, some cases it can mean you have something else going on. I'm sure my daughter got it because I know her immune system is shot. Yeah. And I'll talk more about her in a minute. So how do they treat it now? Acyclovir, that's what they put her on. Sometimes steroids and other things to help the pain. So that's herpes zoster. So how do you prevent it? You can get a vaccination for people over 50. But then somebody told me physician wouldn't give them to them because they weren't over 65. Okay.
What?
A couple other things.
What?
What is this? I call it a bad hair day.
What is that?
It looks like a.
This guy had some surgery, probably maybe cancer surgery in the lower, probably had a cancer in the lower anterior region. And so they did a skin graft. So they did a skin graft from somewhere else, and they did a skin graft with hair. Yes, maybe it was a hairy individual. So, well, yeah, you'd have to shave inside your mouth daily. So this is another case in the clinic that was a student's patient, and the patient was a teacher, and the student told him, well, you got to extract your teeth, you got to have a denture. So the patient worried about it. Well, I can't teach school without teeth. Didn't tell him, well, we can make you take your teeth out and put a transitional denture in right away. So he went home and used dental floss because these things were so loose, everybody was wagging in the wind. The wind blew too hard, it would go up. So he ligated the two together. I thought that was clever. Huh? I was doing good. I think having, okay. All right, let's, no, I'll do one more, we'll take a break. Infectious mono. Okay, and again caused by the Epstein-Barr virus. Epstein-Barr virus can cause several different things, right? One of them is infectious mono. Now, I'm going to talk about my daughter again. She ended up getting infectious mono. She was really, really sick with that, right? And typical thing, she had sore throat, intimate contact, what do they call it? Kissing disease, mainly in college students, because you're exchanging the saliva, right? So 50% of college students have been exposed, but most college students have been exposed. Like most of these diseases, they are subclinical, right? So maybe you say, I have the flu, but actually maybe you had infectious mono, but a very subclinical infection, right? But she was really sick. What's interesting, what her neurologist told her, that I'm seeing a lot of people who have MS who have had a history of infectious mono. So in my mind, getting infectious mono is what caused her MS, and that's why she has shingles right now. All from infectious mono. Now, so you have a sore throat, that's one of the main things, and you have a cough, lymphadenopathy, so your lymph node gets swollen up, fever, all right, and you're really tired. I mean, you're worn out for a couple of weeks, running a high temperature, sometimes you really be sick. And one of the characteristics is about 25% of the people can get petechiae on the hard palate, all right? And that only lasts for a couple days, but just by seeing petechiae on the hard palate, you're not going to make the diagnosis. The diagnosis is going to be made by being sick, fatigue, lymphadenopathy, and things like that. So let's look at some petechiae Here, again, here's some petechiae, what it looks like. And the tonsil areas can really get swollen up infectious mono. All right? Really be very, very painful. All right? Again, this is something Susan put there. It's good. You get fatigue, malaise, a sore throat, tonsils get red and swollen. You can have respiratory problem. Yeah, spleen can be a problem. You have an enlarged spleen, and actually you can have some problems with the spleen afterwards. All right? So it's not a fun disease to get, infectious mono. All right? But again, the petechiae in the palate is something to remember. But that, like I say, that's only going to last for a few days. Anything else that I want to tell you about? And actually, you don't treat them with penicillin. For some reason, penicillin and amoxicillin, people, when they treat them with that, they have a higher chances of anaphylaxis, and I'm not sure why that is. All right. And people that also have infectious mono, later on, they can have other diseases. Chronic fatigue sometimes to relate to that. So it can bring up. And once you have Epstein-Barr virus, okay, you have that virus in your body for your whole life. All right. But a lot of times, most things like that are subclinical. And the lymphadenopathy, you usually see that in the younger people when they have this. In the older people that get infectious mono, they don't have that lymphadenopathy as much. Those are the things. The spleen enlargement. And again, a lot of people will acquire the virus without showing any sign of infection. And that's in your notes, being subclinical. All right. Hey, 3 hours of lecture is a long time for you. Huh? How do you do it? Because you're young. And you're excited.
We're tired and excited.
Now, you guys are juniors?
Yes.
Yes. So you're up in the clinic seeing patients, right?
Yeah.
Just started. All right. Good. I want to tell you something that's really important. I go see a dentist, actually graduates from here, and I go see a hygienist. And I'll tell you, that hygienist, I am amazed with her. My wife went to see her first and said, "Oh, this is the best hygienist I've ever seen." We had great hygienists in our office, in the office that I was part of. But I want to tell you what this hygienist did. I was impressed. And I'm an oral pathologist. She did an oral cancer screening exam. Wow. I mean, palpated my lymph nodes, asked me about one of them. I mean, that was really, I was impressed. Really impressed with the gal. You know, in February, we practiced, and she didn't hurt me, but I wish she would hurt me a little bit, maybe. You know, I mean, it's just like, you know, dentists aren't really good at having their teeth cleaned. Did you know that? And dental work then. You know.
Babies.
Huh?
Are they babies about?
No, you know who are the babies? Having dental work done? Physicians. They do not want shots. Now you get some that are really good, but I'm amazed because when I'm in private practice one day for, I don't know, 40 years, I saw a lot of the physicians here. Can you do it without giving me anesthetic?
You want it to hurt.
But yeah, they are, for some reason, some of them do not want to have shots. Yeah. But then you have it on the other side too. Some are good. Do you know who are your best patients in the practice? They can be the best or the worst. What?
Children?
You know, I didn't work on a lot of little kids. I like that, but I didn't work on them under 5. But I admire dentists who do. My cousin's a pedodontist who went through here. Okay? Older women. Either older women are the nicest that you can find. They are. I love them.
Is sarcasm?
Well, they can't be that way, but they're good about it. But you can also find the most horrible one you want to deal with, too. Huh? Huh? The only ones I have an experience with is women, but not very often. But can they be bad? But most of them are wonderful. The best patients are older women. Yeah. Let me tell you a story. You won't believe this story. I'm glad I remembered this. This is a classic. Okay, so I was in private practice, even oral pathologist. I did general dentistry, all right, but I did, about oral path too. So I had this lady who was about 80. She looked like a wrinkled Peruvian. She spent most of her time in the sun. Just the nicest lady in the world. Okay, her husband died. And I'd done some work for him, and she needed to do a denture, and she came in, Lane, will you make me do a denture? No, I don't make dentures. Well, I have, but I don't like to. Okay. I said, no, get somebody else. No, Lane, will you make it? Okay. Oh, yeah, I'm going to get into trouble. I'm going to make the denture. So I made her this denture, came in, and it seemed to go okay, all right? So she came in for a 2-week check-in. So she got along fine, all right? Just great, all right? So there were 2 dental assistants in the laboratory. When she got out of that chair, she stood up, grabbed me around the waist, pulled me in, and kissed me right on the lips.
Oh my gosh!
And the mouth of those 2 assistants went. And she said, I want to tell you, I can kiss with these like you can't believe.
Oh my God!
And I told her, I said, you know what? That is the nicest compliment I have ever had in my life. I loved it. Okay? I thought, and she caught me by surprise. Okay? I thought, wow, I like telling that story. I will never forget that. He said, man, I can kiss with these new dudes. And I'll never remember, I'll always remember the look on those 2 assistants' faces. I'll say, wow, that's a compliment. Okay, break time. Okay, when you come back in 10 minutes, we'll finish up by 10:02.
Oh yeah. I know it, but I just don't know.
So now, do you get a quiz over this material, or this will? Did she quiz you on everything?
Yeah.
When did she quiz you over it?
Next Friday. Next Friday.
Oh, next Friday?
Yeah.
I don't know if she'll ask me to make up the quiz or not.
I've been about half.
Is this the one you're looking for?
I was gonna go to around like 8:30. You have like and then we're gonna go see
Or you can change it like you're okay. I don't know where I'm going
I'll just
sit in that chair now. Right.
When does he find out about his little nasal? When he found out about it, right? It's not.
He's fully going to this.
He's busy.
He always waits until it's too serious. Like, oh, guys, I don't know. Something. And then he always says, I'm so mad. Well, you got me. You got me. Symptomatic you're looking for. You got me. And my mascara is from yesterday and it's so chunky. No, they just are chunky.
If I have my mascara on,
They get sore and then fall out.
yeah. Those birthday socks.
Yep.
I was eyeing those last season.
Girl, I got these on sale.
When?
Like, no, like 4 weeks ago.
Where?
Back in Pasadena. There's just like I know people can hear me coming.
Okay,
They're so
When
comfortable.
you look at shoes online and you're like, how if they were rigid or like. Okay, well that makes sense. I love that. No, it doesn't bother you.
My sisters were boo-booing me about these socks. I was like, so comfortable, and I think they're cool.
No,
They were,
socks I
they're like, wow, really?
My eyelashes were so my
These
mascara.
were, I got these 30% off. So there's a place in Pasadena called European.
And I had the gym last night, so I sweated in it.
They're
So
based
they're all
they only get
together.
European shoes. They also do nursing shoes, like the dance shoes. All that stuff. So they had like a
I never do, honestly.
Really?
Yeah, especially when I go out. Oh my gosh, I just take half my eyeliner off.
I could have got just a little bigger.
When I go out, if I have something to do the next morning,
I have like a wish
so like one day I went out and then I think I had school the next day.
Is my favorite.
I didn't care with my makeup because I mean, it was a little messed up.
So it was the
I just been too lazy to take it off and put new makeup on.
Yep, here they are. That's from like last year. I don't think it's from last year, but yeah, they're from last year.
Yes, yes. Hold on, let me show. Yeah, so this is in South Pass. So they have all, like, in there, they have all the comfort. But then right after that, they have all of them. And they even have, like, the herpetic.
Okay, let's get started.
All right. 38, so
You know, back in the early days, we didn't have a computer. Every class, you had to take everything by notes. Can you imagine everything? They didn't have slides. Just when I started, just the person got up and lectured. You
You write everything.
had to write everything, but you did have textbooks. But
Okay, I have two Daniel. Tell me which one to write.
they didn't even have Xerox machines back then. So when they made out tests, they had to do it in these carbon copy things. Secretary had to type it out, you know, like 2 carbon copies, and then run it through a machine. So if you type something wrong, you had to take it out, the old typewriter, and correct the carbon copy on it.
Now we take our tests on our computer.
Now you take tests on a computer. Yeah.
It's like crazy. What year did you graduate?
I graduated 65 from here, and then oral path I graduated in 74.
No, I didn't.
So, one class they had a hard time filling. Was that last year or something? Was the class ahead of you smaller than your class? So they didn't fill the whole class that year or something, right?
Yeah, ours is the biggest class.
Yeah, you seem like you have a lot of students. How many? 41. 41.
Yeah, we built it up with 42.
Yes. I thought sometimes the full class was about 44 too, but maybe they never done that. No.
We had 44 or 30.
Okay, yeah.
So it's just like the worst thing that we're using is I think it has a trigger, but I mean.
Okay, we'll go ahead and get started with who's here. This is kind of a unique condition that you don't see too often. Although back in the 80s, when we saw this condition, usually the diagnosis was somebody who had HIV. And they really didn't diagnose this condition. If you look in an older textbook, it's not going to even be in it. They call it oral hairy leukoplakia. So you've had leukoplakia, right? Yeah. Okay. So what this condition is that you actually have leukoplakia on the side of the tongue. And the leukoplakia is kind of like hair-like, looks like little, I don't know, projections that look like hair. All right? And it's caused by a recurrent Epstein-Barr virus infection, okay, in a immunosuppressed host. So you didn't see that before, or at least they didn't notice it. But, when AIDS came out in the 70s, if I remember, all right? So sometimes what we'd see on these patients is this oral hairy leukoplakia. And if you saw a patient with this, you suspected this patient had HIV infection, all right? So it was more or less oral hairy leukoplakia went along with the HIV infection. But now that has changed. Now you can see right here, now known to occur in non-HIV infected persons with severe immunosuppression, like in transplant patients. If for some reason, if your immune suppression is suppressed, you can end up with this. All right. So it's very characteristic. Although it's hard to tell sometimes by just general leukoplakia, because people that chew on their tongues sometimes, you can get what? You can get leukoplakia on the side of the tongue, right? By trauma, all right? So let's take a look at this. Here's the clinical features of it. It's very characteristic. Although this one, I don't like the picture. It's not real typical. I mean, to me, that looks more like leukoplakia. If you saw that lesion by itself on a person, what would you think of? Well, it looks like maybe you have a little tiny, maybe a little ulceration there. But if you got the white area, when you have leukoplakia can be what? Pre-malignant, right? Right. Leukoplakia is a pre-malignant lesion, right? So when I looked at it like that, so what would you ask about this patient? Is he a smoker, right? That causes leukoplakia. Or does he have a sharp tooth on one of the lingual parts on his mandible to do that? So you would want to rule out any type of trauma. Trauma can cause leukoplakia. Now, trauma that causes leukoplakia is not pre-malignant. But if you have leukoplakia caused by trauma, that's irritational leukoplakia. That's not pre-malignant. But if you have leukoplakia caused by, say, you're a smoker, okay, then that could be pre-malignant. So leukoplakia can be what? You've had leukoplakia, right? No? You had squamous cell carcinoma?
Yes.
Well, you had to have leukoplakia then. You have pre-malignant lesions? So leukoplakia can be benign. Now, white lesions don't wipe off, right?
Yeah.
Okay, so leukoplakia, most of them are benign, but it can be pre-malignant. You have some abnormal cells. If you have abnormal cells, it's pre-malignant. Pre-malignant means it could go into a cancer, right? Not necessarily going to be, but a pre-malignant. Or you can have outright squamous cell carcinoma. The only way you tell the difference is do what? Biopsy. The only way you can tell the difference. Now this is more, looks like oral hairy leukoplakia. Very characteristic. Looks like hair-like type of things. So clinical features, shaggy, white plaques, corrugated, corduroy-like surface. I've never seen that term before, but I like that. It looked like corduroy. I mean, it's a great term to describe it. Dr. Richard put that in there, really like it. Lateral borders of the tongue, you're going to see it. Bilateral, fairly symmetrical. Other oral mucosa may occasionally be involved. So back in the earlier time, when we saw a patient like this, that was hard because you say, hey, I mean, you didn't want to tell a patient or ask a patient, are you HIV positive? So that was a little tricky, but there were some other conditions you'd see in an HIV patient too that would help you make the diagnosis. But you had to think about that back in those days. So here's some more. Again, I like that other one better. This is really thick. I like that other picture. That one's better than this one. All right? When you think of corduroy type of things. Okay, prior to HAART, what is that? Are you familiar with that? I had to write it down. Highly active antiretroviral therapy. Yes, heart. That's heart. So, again, with all these drugs, again, an HIV patient, that they can keep from coming down with full-blown AIDS. So on those patients, on oral hairy leukoplakia played in the late asymptomatic period of HIV infection, most patients developed, that was prior to that, most patients that had this came down with AIDS, all right? But now, since the advent of that, appearance of oral hairy leukoplakia indicates failure of the heart treatment protocol, okay? So it's heart treatment is not working. Our compliance problems with the development of resistance to antiviral drugs is not working, so maybe you need to try different things. So you don't necessarily have oral hairy leukoplakia, meaning the patient has AIDS, because it's going to be on immunosuppressed. Okay. Oral hairy leukoplakia itself does not require specific treatment. You don't need to treat it. Usually it doesn't bother him. Treatment of patients with oral hairy leukoplakia depends on the HIV status of the patient. So the status possibilities. HIV status may be unknown. So if they have that and they're not on heart, you may want to do a biopsy or check that they may have AIDS. That's a possibility. So patients don't know they have it. So your chance of seeing this, you may see it. Sometimes it's just hard to tell from other conditions. All right. So that's oral hairy leukoplakia. Used to see that, but don't see it so much anymore. Enteroviruses. Okay, let's talk about those a little bit. There's more, about 30 of enteroviruses, Coxsackie and things like that. Two main lesions we're going to talk about: herpangina and hand, foot, and mouth disease. All right? The herpangina is caused by different groups. Group A, 1 to 6, 8, 10, 16, and 22. Some other ones can cause it too. Does she get real specific in quizzes? You don't have to learn all those, do you? I don't think so either. Yeah, just to know it's Coxsackie group. All right? And hand, foot, and mouth disease caused by group A16 can be caused by other ones too. All right? Now, these usually are young people, all right? And you can have asymptomatic lesions on these too. Now, as far as, let's see what else I want to say about it. Okay, herpangina, actually some interesting things here. Most cases, like I said, are subclinical. And most of the time you see it is in the summer and fall in herpangina. You get it through contact with saliva, or most of the time through oral fecal route. Interesting, in Taiwan, back in 1998, and these kind of things, you have an outbreak. They had a huge outbreak where out of 21 million people who live in Taiwan, 1.5 million people ended up with herpangina, all right? And so it runs into things like that. And actually, they had a couple hundred people that died because of that, all right? So remember, this is usually young kids, all right? And so summer months, routes of transmission, oral fecal route, saliva, incubation period 4 to 7 days, all right? But I stress, a lot of these cases are subclinical, they're never diagnosed as such. But these are both of them are very characteristic. Herpangina, most of them 1 to 4 years of age, flu-like symptoms, all right? Resolves in a few days. You don't really have to treat it, take care of the fever, things like that. What they get, red macules and vesicles, and then they get ulcers. They get them on the back of the throat, on the soft palate, all right? So they get a vesicle and then an ulcer back, and also in the tonsillar papilla. So the ulcers resolve in 7 to 10 days. What could you get this confused with? What else did I tell you that had vesicles back in the soft palate? I showed you pictures of a lot of vesicles today. What? Herpes or Apthous? Herpes. The ones where it usually occurs where you get herpes in the pharyngeal area is in older adults, right? But this is young kids, usually, all right? So it helps you to differentiate that way, right? All little facts here it's easy to get confused from one to the other. Let's show you a picture. Here's some pictures. Classic. This one up here, I mean, if it's just in a soft palate for a person's running a fever, I mean, just by looking at it, you have to have other factors, flu-like symptoms. You just can't look at this and say, I mean, this could be, it could be Apthous. Could be herpetiform Apthous. Yeah, could be. But in herpetiform Apthous, the difference would be, they wouldn't be just usually in the soft palate. They would be everywhere, right. Yep, you got it right. Here, you see, here's some here too, and one there. So herpangina, again, usually young, as your notes say. Do you people read stuff out of the book too, when you study? No, you just read the notes. People don't read books anymore, do they?
There's no time.
No time.
We don't have time. She suggested that we stick to the info she gives us.
Do what?
Stick to the info that she
Oh, on the notes, yeah. Because we usually took the quizzes off that. Hand, foot, and mouth disease, same thing. You get young kids, flu-like symptoms, same thing, so that goes along, like herpangina. And you get these lesions, few to a dozen. Primary effect, just a name. Hand, foot, and mouth. Usually you see it a lot of times in the hand and in the mouth, and it could include the foot. It doesn't all necessarily have to be all three, but begin as erythematous macules that develop into a vesicular lesion. All right? And very characteristic. And again, you get them through periods where people will break out that at one time. Let's take a look at hand, foot, and mouth disease. Okay, oral features, they resemble herpangina, okay, same organism. Numerous ulcers, 1 to 30, confined to the posterior area of the mouth, okay. Most common area effects are the buccal mucosa, labia, and tongue. Well, not confined, excuse me. Yeah, when I read that, confined. I said that didn't make sense, but I didn't see the not. Okay. Vesicles don't stay very long in the mouth. Not very often you're going to see a true vesicle. In benign mucous membrane pemphigoid that you guys had tests on today, not very often would you see the vesicles. Sometimes you would. And one of your questions today was really good. Well, she said that afterwards. the vesicles stayed longer in benign mucous membrane pemphigoid or pemphigus?
Pemphigoid,
In pemphigoid. Why?
because there's more tissue.
It's deeper down. It's at the basement membrane. Yes. What would you rather have? If you had one of them, if you had like erosive lichen planus, benign membrane pemphigoid or pemphigus, what one would you choose if you had to have one of those?
Pemphigoid. Mortality.
Well, but I said erosive lichen planus too. I'd choose erosive lichen
Oh
planus.
yeah.
I wouldn't want to have pemphigus. Yeah. And even benign mucous pemphigoid is mainly the gingiva. Could be the eyes. I mean, if she didn't give you that eyes on that quiz today, you would not have known the answer. You would have to say, I'd say 3 different lesions. Erosive lichen planus, pemphigus, or pemphigoid. Yeah, I'm getting off the subject. Here's hand, foot, mouth disease. Here it's on the posterior part of the palate. Here it is, you can see it on the foot, and you can see it on the hand. Very characteristic. Here's some more. These are from our file. But remember, flu-like symptoms. Here's a couple of things, more pictures. Patient came in one day and she had this. I thought, well, that's a good way to close a diastema. And then I was doing the exam on a patient, a gal up there in the clinic about 45 years of age. I'm doing an exam. I saw this on the side of this crown. And it said sex. And I said, you got to tell me about this. Why do you have this on here? He said, well, I knew the lab technician. I thought that would be just kind of cute to put that on there. So she had it painted on there before. I said, well, okay, can I take a picture of it? She said, yes. I said, because I have no pictures of oral sex. I'm taking a picture of it. So don't go around and tell people that I showed you pictures of oral sex today. Okay? Okay, Candida. Common. You're going to see Candida. All right? Candida is an organism that most of us actually have in our mouth. In 50% of us, it's there, but it stays under control. Other flora kind of control it. But some things that happen to the environment or our systemic system actually can make that opportunistic. I can't even get the word out. Sometimes I can't. Words don't count when I'm in these. Help me with the words. Okay, so it is the most common fungal infection. All right. So who are you going to see it in? What do you think? Sometimes young, very young can have it. Okay. Older patients can have it. Autoimmune. Are they listed here? Oh, okay. Oh, you're looking up on the... block the screen. Okay. Diabetic patients. Anybody that's immunosuppressed. Okay. Denture wearers. A lot of denture wearers have candida. All right? I mean, normal people can have candida. All right? And here's another common one. If you're on antibiotics too long. Candida likes any moist area. On the skin, genital area, inside the mouth. All right, just a common organism. Now there's several manifestations of Candida. This is one of the most common ones. We'll talk about this in a minute. This is a pseudomembranous type. Okay? Now, if you saw this patient came into the clinic and you looked in the mouth, what's the first thing you'd want to do? Scrape it off. If it didn't scrape off, your clinical diagnosis would be what? Hyperkeratosis or clinical leukoplakia. All right, leukoplakia is only a clinical term. All right, so this scrapes off, so we have a pretty good idea. This is a young person, healthy person. When did this show up? It showed up when he had braces put on, which is interesting. For some way, it changed his oral environment. I don't know how, but then he ended up with this type of pseudomembranous candida. And So when you scrape this off, they used to say they look like milk curds, okay? Then often you get little pinpoint bleeding spots because the candida kind of burrows into the upper layers of the epithelium. So if you rubbed it hard enough, you can get pinpoint bleeding areas, okay? Now, here's the types. Pseudomembranous candida, erythematous, and median rhomboid glossitis, and angular chylitis. These are the ones that you're mainly going to see. This chronic hyperplastic candidiasis, it's a candida that's in leukoplakia. You're not going to see that very often. And here's somebody who's got really immunosuppressed condition. All right? These are the main ones. Pseudomembranous is often the white one, the milk curds. All right? Why did that do that? Oh, there we go. So let's look at this. Also called thrush, is the most recognized form, often associated with antibiotic therapy. Sometimes you get a burning sensation in the mouth. Not always, but you can. I have seen patients with that. You get these creamy white plaques that wipe off to reveal erythematous area. Common sites, buccal mucosa, the tongue, the palate. Palate's a common site. All right? They can be anywhere. Here are some more. Now, this came from our files, and it's not a patient I saw. That is really piled up there. I mean, you know. But here, this would be common in a young person would wipe off. And here, in a denture wear, all right? Right? You have to differentiate that from leukoplakia, which leukoplakia would not wipe off. All right? But often you'll see it, dentures patients do have leukoplakia. Now, the erythematous type, so leukoplakia, candida doesn't have to be white. It can be red, all right? And so that's the erythematous type. Often you'll see this in a denture patient. So it is a trophic type of candida. They also call it denture stomatitis. That makes sense because you see it in denture. But you can see the pseudomembranous in denture too. So you can see both types in denture patients. The interesting thing about this one, often they'll have a burning syndrome. A burning to their mouth. There's a thing in dentistry that you see hard to treat called burning mouth syndrome. Have you ever heard of that term? Burning mouth syndrome is when you start getting mouth burns, mainly in women. Middle-aged women have this burning mouth syndrome. And it's like they drank hot coffee that scalded their mouth. All right? And it's hard to get rid of, hard to treat. All right? And sometimes what can cause that is erythematous candida. Not always, but it's one of the causes. So when I saw patients with burning mouth syndrome, very seldom would ever be a man. All right? Some things that can cause it is trauma. Some people have a habit of going like this with their tongue, and then the tip of their tongue burns all the time. So trauma can cause burning mouth syndrome too. But sometimes candida will cause it. And the first thing I do on these people, I put them on an antifungal medication. And a lot of times that helps. All right? So they can lose, when you get this, they can lose the filiform papillae, so they get a bald tongue. And I'll show you some pictures of that. Common sites can be anywhere. But the tongue can be a common site. And look at the tongue. Look at the tongue on the right-hand side. No, the papillae, they're gone. That tongue hurts. That's like you drank hot coffee and you got a tongue that's just burning all the time. Really a condition. I saw oral path patients, but when I would tell the receptionist up front, if somebody calls in and they say they got a burning mouth, or send them to another oral pathologist. I don't want to see them. It was hard to diagnose. So I had a friend who liked those things. So really difficult, but mainly middle-aged women would have that. Now, here, look, you see that tongue on the right-hand side? Well, I added this slide because out of my theories. It's the same case, but look at the gingiva on this patient. That looks like periodontal disease or an allergic reaction, right? But it's an erythematous candida. So you treat them with an antifungal. I tried to find that case too. I have a picture of a young girl that all the papillae is gone on her tongue. They treated her for antifungal for 1 month. all the papillae came back, and she had a normal-looking tongue. So that's the erythematous type. Okay, median rhomboid glossitis. Do you ever run across this term? Okay. This is an area, erythematous area, located in the midline of the tongue. It's a bald area in the middle of the tongue. Not very often. They used to think it was a developmental problem. But then somebody looked at 10,000 young kids and you never saw one case. They say, wait a minute, this can't be a developmental problem. It'd be on young kids. So what happens, they lose the filiform papillae in that area, the middle part of the tongue. Why that area? Maybe the blood supply is not so good. I don't know. It'll give you another possibility too. And sometimes if you treat them with antifungal therapy, it will come back. Let me show you how it looks. This is not a typical. It's not a typical slide. In fact, this is more typical. If I showed you this, I wouldn't make you come up with a diagnosis. If somebody showed me that, I'd have a hard time diagnosing. That one I could. Maybe here's a dental student. Take a picture of, like that. That's what it looks like. The papillae's gone. But where does that part of the tongue hit in the mouth? What is this opposed to? The palate. Where did I say you had a lot of? Let's go back and look at this. See that palate? So maybe when you had a infection that's in the palate, when it's a kissing lesion with the tongue, maybe that's a possibility. I don't know. But I thought that's a good picture. That was, like say, of a dental student. Angular cheilitis. You're going to see this in older patients. It doesn't have to be older patients. But you get these areas in the corner of the mouth that get really sore. A lot of times in denture patients who actually lose their vertical. Let's say their mouth closes. Or somebody, you ever see these homeless people now? Not necessarily homeless, but people are, because of drugs, the teeth are gone, so, their nose and their chin come closer together than normally. All right, so what happens, they end up having a lot of angular cheilitis, all right? And it's due to the wet, moist area all the time, and the bacteria gets in that area, all right? It can be quite sore. It says here, aging and loss of vertical dimension. If you made a denture where you're closed too much, that can cause it. And also you see it in immunosuppressed people, and vitamin deficiency can do it sometimes too. But you would treat this with antifungal, or I treated it, it's not listed in your notes, is something called mycolog. It's antifungal, antibiotic, and steroid, a mixture of all three. And it really did that. But angular cheilitis, you're going to see that in patients, a lot of patients, and they should have a prescription for something that will help that. And I think she lists here a type. Here's some more. Here's on a young kid, typical with the braces. Sometimes it can be crusty like that, or it can look like that. I mean, that can happen to a normal mouth sometimes. We get that. But you treat it with medication. Here, usually treated empirically, topical antifungal agent, niacin, oral suspension. If it's intraoral, this is for candida. So that's how I treated candida. You treat them with antifungal, all right? They could be a suspension where they swish for a couple minutes, spit out. Do that several times a day, okay? Or you can use niacin ointment in a denture. That helps, okay? Or another one is Mycelex. These are atrocious that they suck on, like 5 a day, all right? That will take care of it. And also you can tell them that they can use the vaginal ones, but it's hard to tell somebody to buy the vaginal ones and suck on them. It works, actually, but it's not the best way to do it. Also, diflucan, it's a systemic one. It works really well, too. Most of them that I use was Mycelex. And on topical ones, I use niacin. A lot of times I've used niacin oral suspension. So you should be aware of niacin, and you should be aware of diflucan and Mycelex. Those you should be aware of. All right? Okay, last couple here. Oh, we're going to get done on 10 minutes. Okay, no problem. We only have what? Just a couple of entities left. Okay. Histoplasmosis. Again, deep fungal infections caused by Histoplasma capsidulum. Most common systemic fungal infection. Fungal infections, a lot of times you inhale the organism and it can get into the lungs. Most cases, again, are subclinical, and then you have flu-like symptoms, all right? It infects a lot of people. This one is mainly in the Mississippi, Ohio and Mississippi Valley area. 1.5 million new cases a year. And again, flu-like symptoms is what you have. A lot of people, it's subclinical. Hey, what are you doing? Huh? Man, my old girlfriend.
I'm leaving for a mission trip, so.
Oh, well, it's good to see you.
I was supposed to do an introduction this morning, but I
Oh, God, that's right. I wouldn't want you to tell anything about me, so good thing you did.
we didn't even gone on vacation together.
Aww.
Take care.
She and her friend came up and we had a wonderful trip to Northern California. Got some great pictures. Anyway, this is interesting. Now, let me tell you something about this one. Oh, us that live in California, we have a similar one that can cause it, and it's listed down your notes too. What is it called? Valley fever. It's caused by what? Coccidiomycosis. All right? And she has it listed in your notes, but she doesn't get any information about it. So what these things can cause, flu-like illness, 1 to 2 weeks, acute. Most cases it's self-limiting. You just get it, you have a cough, you don't feel good, and a chronic cough, and then it goes away. But on elderly people or an immunocompromised person, it can get into the whole body, and you can have disseminated type, and it can cause death. I've had 2 patients of mine who died of coccidiomycosis, valley fever, all right, was very similar. And here are the lesions in the mouth, very aggressive. I mean, nothing characteristic, it's just ulcerations. Those things can get into the tissue, into the bone, and dig deep, and you would deep into it, and you would know it by a biopsy. Oops. Diagnosis, oral lesion usually required biopsy. All right. So actually, you can find an organism within these large cells. Okay. And it can mimic oral cancer. That's one thing about these diseases. Here is a couple more. Look how it's just going right through the palate. A lot of times it gets in, and the only way you can treat these things, like coccidiomycosis 2, amphotericin B, which is a really strong antibiotic, can cause liver damage. All right. Mucormycosis. I don't know much about this one. She put it in there, but it is again a fungal organism that you find in fruit, vegetables, or bread that's moldy and things like that. All right. Again, it's an opportunistic organism. And can cause serious invasive infections. I'll let you read that one on your own. I don't know that much about it, but look at it. So surgically, so you're going to see it in patients, mainly diabetic, which is listed in your notes, or bone marrow plant recipients would have this, AIDS patients, anybody who's severe immunosuppressed. So it does a lot of destruction, necrosis. Look at that. Isn't that a nasty looking lesion? So surgically, they have to go in and take that necrotic tissue out. Blastomycosis, again, somewhat same thing. I put this in here, but she didn't list it. But it's similar. I'm just going to show these pictures. She doesn't have this on your notes. And then coccidiomycosis, San Joaquin Valley fever, same thing. You inhalation of dust-contaminated spores, and you get flu-like symptoms. And I'll just show you a couple pictures. Actually, it can get into bone. Lesions on the skin. All right, but I just threw those in. But we don't have time to talk about it. Okay, couple impetigo. Okay, caused by strep or staph. All right, and you get a little ruptured area around the mouth. And then an organism, either strep or staph gets in it, then it gets crusty, it gets infected, contagious, all right? And
So you have the strep, you have the staph. Both can be present. Sometimes it's one or the others. Skin barrier has been compromised, and then your organism gets in there. And it can be anywhere in the skin. It can be on the legs, but the ones we see are usually around the mouth. And you can have vesicles that ooze, and then you get an amber crust, and it can look like glued cornflakes on the area. And very contagious. I like that term, the glued cornflakes. So here's what it looks like. So you'll see that once in a while. You could confuse this with what that we've seen? You could use it with primary herpes. Or you could confuse it with herpes zoster, right? If it was just on one side. But really could confuse it with herpes. But talking about that cornflakes on there, that makes sense. So treatment, again, antibiotics. All right. Okay, necrotizing ulcerative gingivitis. You probably have this in perio. They don't call it acute necrotizing ulcerative gingivitis anymore. They call it just, because it's not acute, it's a chronic thing. Trench mouth. Why do they call it trench mouth? Because in the World War, when people were in the trenches, they didn't have good nutrition, so they ended up having this. All right? And that's where the term trench mouth. And you'll see this in patients. All right? And it's caused by several different type of organisms. It's in your notes. All right? And also, they used to call it Vincent's disease. Okay? So there are a lot of organisms that contribute to that, but here's how you make the diagnosis. You make the diagnosis when you walk in the operatory, because you can, such a foul odor from the person's breath. Okay? And it's very, very characteristic of this disease. This is in your notes, okay? But it's usually people that, again, that are not doesn't have the right nutrition. Middle-aged people usually. One of the characteristics is swollen gingiva, and the interdental papillae becomes necrotic. It's just punched out, and this is very characteristic. All right, that interdental papillae of that, and you'll have this in perio also. So here's what it looks like. So how you, and you see quite a few of these patients in private practice, not so much anymore, but usually you put them some type of mouthwash and you scale the teeth and get them on a good diet, and usually it takes care of itself. Okay, periodontal debridement, ultrasonic cleaning, irritant, chlorhexidine works really good, and antibiotic rinse works good. Sometimes in systemic will do it. Actinomycosis. Okay, this is an infection again caused by actinomycosis isarelli. Is a bacteria, and there's several types. You can have the cervical type. Most of the cases are that. You can have abdominal pulmonary type. We're just going to look at the cervical type. One characteristic of this one is actually what happens is if you have a tooth extracted, the organism is normally found in the mouth, but the organism likes to burrow down in things. So if you have an extraction, the organism likes to get into a socket, but it burrows down with like where gravity goes, and then you can get fistulas that come out. And you get these little, the pus that comes out has little yellow areas of the organism, and they call them sulfur granules. They're not sulfur, but they look like sulfur granules. So it was easy to make the diagnosis because of those. All right? So often it is in this area, as somebody that has one. This is classic. Having these fistula tracts. Maybe there's a history of an extraction in that area. So you can find actinomycosis in perio pockets, in an abscessed tooth, a lot of different areas in the mouth you can find it in. Now here's a lady in the clinic that I saw. She had this draining fistula tract all the time up in the clinic, and here's what was draining. They actually did a biopsy on it, but they couldn't see anything. But there were little tiny sulfur granules, looked like sulfur granules, with the organisms themselves that came out on that. And here's another guy, I'm going to skip over that. But you can even find actinomycosis in radiographic radiolucinal lesions. Okay, here's the last one. I got 1 minute. Okay, cat scratch. You need to be careful with cat scratch. Kids that are around cats, they can scratch you, And then what happens, a few weeks later, you end up with the lymph node swelling up. Hard to make the diagnosis. They used to think it was a virus that caused this, but it's not. It's a bacteria, okay? And it can be caused by fleas. So if a kid gets scratched, and sometimes you won't even know they got scratched, but they end up with this node that swells for a couple months, and after a while that node will go away, but it gets huge. So the node develops in 2 to 3 weeks after the cat scratch, and these things can get really big. And I'll show you, here it is. Painful lymphadenopathy. A lymph node can get enlarged in proportion to the size of the original wounds, which is scratch. Okay? May get rash, fever. Self-limiting, and here's what they look like. I'm going to show you a better picture. No? Do I have a better picture? No, I don't. Okay, but I'll let you read that. I want to show you a couple of things before I leave. I got 1 minute. Okay, look at this. Here is a picture we took in the clinic, and here is a radio-opaque area. Here's another one in the clinic. Here's another radio-opaque area. Any idea what those are? I'll do that quick. Here, this one was a bead stuck in the nose. All right, in the patient. This was a BB the kid had stuck in his ear years ago.
Oh my God.
Okay, here's the last one. Okay, one of the hygienists was doing a prophy upstairs on a guy who had deep pockets. As she was scaling the pocket, she flipped this out.
Oh my gosh.
You have any idea what that is? So she brought it to me and said, "What is this?"
What is that?
Like a little tooth.
What is this? No, soft. You could break it. I had to be real careful. This is very fragile. I've read other things of this before. They've been in the paper. This happens.
So where was this?
This was in the mouth, upstairs. Hygiene student flipped it out of a deep pocket, a deep 9mm pocket.
Is the whole thing hard or soft?
Soft.
It's soft.
Yes.
Tumor.
No ideas.
No.
All right, come on. It was a sprouting tomato seed. Yes. There've been other things about it.
You?
Yeah, it was a long time ago. So I found somebody with a tomato plant, put it in my mouth just to show you it.
Oh my God. So handsome.
Okay, as we end, the last couple of things we went through fairly fast, but read those over. You got good information. All right, we'll see you guys. Good class. Thank you. Maybe we'll see you soon. If you see any sprouting tomato seeds, send them to me.
Physically send them to you.
So can you convince Dr. Richardson to give us answers for the final?
Yeah.
Yeah, please. That'd be awesome.
Oh man. Did you ever have rose-colored glasses?
Pardon?
Did you ever have rose-colored glasses?
No, I put those on so people wouldn't recognize who I was.
Oh. My dad has rose-colored glasses.
No, I never did.
Bit out.